We are live now.
So, good evening, friends, and good evening to all the AIOS members as well as to the participants in today's webinar. Welcome to this monthly webinar on behalf of Academic and Research Committee of All India Ophthalmological Society. So today we have a slightly different theme. Everyone says that every day we learn one or the other. Every new patient teaches you something or the other. So a very well designed webinar, courtesy Dr. Tinku Bali. Thank you, Dr. Tinku Bali, for organizing and getting such young speakers for today's webinar. And also equally important, the seniors who are going to help us out in deriving the pearls from the cases which the younger Turks are going to share with us. So without much ado, I would request Dr. Tinku Bali to carry forward the further proceedings.
Thank you,
Tinku.
Dr. Prashant. As you mentioned, today's episode is special because in today's episode, we'll be going beyond textbooks and trials, and we'll be giving you some real world scenarios that taught us something. So, from OPD decisions to OT dilemmas, today we will highlight cases that challenged, surprised, and gave us some learning lessons. Each speaker will present a case for 5 minutes, followed by a discussion by the discussant. So, I request the speakers to stick to their a time limit of 5 minutes. And joining me as a co-moderator is Dr. Deepak Mishra. He is a member ARC from Central Zone and is a professor at the Regional Institute of Ophthalmology at BHU Varanasi. So welcome, Dr. Deepak. And before we start the webinar, I would like to welcome not only the speakers, the discussants, the chairpersons, but also the audience that is there with us this evening. I would like to welcome our chairpersons. We are truly honored by your presence here this evening. And we have with us Dr. Mohan Rajan sir, Dr. A.K. Grover sir, and Dr. S. Natarajan sir. So we know them very well. They all are stalwarts in Indian ophthalmology, and their contributions to academics, to research, to mentorship have shaped generations of ophthalmologists. So we are truly privileged to have your presence here. Thank you so much for sparing time for this webinar.
Welcome.
I know that we all know them very well, but just a small introduction to each one of them. Dr. Mohan Rajan is the chairman and medical director of the Rajan Eye Care Hospital at Chennai and is a pioneer and innovator in anterior segment surgery. He's also trained in posterior segment surgery, something that we don't know. Dr. Rajan is the vice president of the AIOS, and he is soon to be the president in 2027. Dr. Rajan brings with him not only immense academic wisdom, but also a special dash of humor that makes learning so very interesting and memorable. Thank you, sir. Thank you so much for your presence.
Thank you, Tinku. Thank you. It's a pleasure to be here.
Our pleasure too, sir. We also have with us Dr. A.K. Grover, sir. Dr. Grover is the founder director of the Vision Eye Care Center at New Delhi and a senior consultant at Sir Gangaram Hospital. He's a world-renowned authority in the field of oculoplasty. He's the president of the Oculoplasty Society of South Asia and the Ocular Trauma Society of India. And he's also been a past president of AIOS. So welcome, sir. It's a real pleasure to have you here this evening.
Always a pleasure to be part of ARC programs.
Thank you, sir. Our third chairperson is Dr. S. Natarajan, who's the chairman and the medical director of the Aditya Jyot Eye Hospital at Mumbai. He's globally recognized for his expertise in vitreoretinal surgery, and he's also been a former president of the AIOS and the Vitreoretinal Society of India, as well as many national and international societies. And Dr. Natarajan's love for ophthalmology is rivaled only by his love for traveling. So a true globetrotter. Thank you, sir. Privileged to have you here this evening. And with that, before we begin, I'd just like to exhort our audience to please keep the questions coming in. We are live on Facebook as well as on YouTube, and you can post your comments and questions in the chat box, and we'll take them up from there. So with that, let's dive into the webinar, and I invite our first speaker, Dr. Rakhi D. Cruz, to present her case. Dr. Rakhi is a phacosurgeon and a medical retina specialist at the Chaitanya Eye Hospital and Research Institute at Kollam in Kerala. So, Dr. Rakhi, I request you to share your slides. And she'll be presenting an interesting case of recurrent scleritis in a young patient.
Is my slide visible, ma'am?
Yes, it's visible. Yeah.
So at the outset, I would like to thank Dr. Tingu ma'am and also to ARC for giving me this opportunity to present my interesting case here. So I'll be presenting a case of a recurrent scleritis in a young adolescent. Look beyond the eye to save life. So this is a 15-year-old boy who was studying in 10th standard, came with redness and pain in left eyes in 6 days. Eye pain was severe enough to awaken the patient from sleep. He also had frequent recurrent episodes of headache and eye pain. There were multiple episodes managed conservatively with topical steroids at various centers. Prior diagnosis from prior records included scleritis, uveitis, conjunctivitis. And probing onto his past medical history, he had significant episodes of bronchial asthma since childhood, recurrent history of allergic rhinitis, sinusitis associated with headaches. He had taken MRI multiple times for his headaches, irregular management, on and off inhalers, on and off antibiotics, no definitive diagnosis or systemic evaluation done properly till date. On presenting to us, vision was 618 in right eye, which was improving to 66, and the left eye it was 6 by 36, improving to 6 by 18. Right eye was essentially normal, but in the left eye there was lid edema, diffuse conjunctival congestion, but it was more pronounced temporarily with dilated and tortuous episcleral and scleral vessels. Tenderness was present, and fundus evaluation showed that there was a shallow serous elevation involving the posterior pole. We did an OCT macula which showed that there was subretinal fluid causing a serous detachment of the neurosensory retina involving the macula without intraretinal cystoid spaces, suggesting that there is some inflammatory etiology. We did a B scan which revealed the diffuse scleral thickening with a characteristic T sign confirming the diagnosis of posterior scleritis. So initially he was started just on oral indomethacin, topical prednisolone, nepafenac eye drops. A complete uveitis workup was done. ESR was marginally elevated. Rest was normal. Once TB and other infectious etiology was ruled out, systemic tab omnicotil was started at a very low dose of 20 milligram once daily, and we sent the patient for a rheumatology consultation. The rheumatologist did a total rheumatology workup. Everything was normal except for a marked peripheral eosinophilia. However, there was rapid improvement in his ocular pain as well as in his conjunctival congestion, and OCT showed that there was progressive reduction in the subretinal fluid. Because of this positive response, we augmented the steroids to 30 milligram twice daily based on his body weight. There was complete resolution of the serous detachment within 10 days. Steroids were tapered over 1 month. BCVA improved to 66N6 in both eyes. However, 2 months later, the patient developed sclerouveitis, this time in the other eye, limited to anterior segment, which resolved completely with topical corticosteroids and systemic anti-inflammatory agents. Approximately 6 weeks later, again he presented with bilateral severe ocular pain, decreased vision, and metamorphopsia. BCVA was 618 in right eye, in left eye it was 6 by 36, which was not improving with pinhole. There was evidence of a prominent pars planatus with spillover anterior uveitis and serous macular detachments. This is a fundus photo. OCT again showed that was macula involving serous detachments of the neurosensory retina. Left eye additionally showed elongated photoreceptor outer segment and irregular retinal pigment epithelium, which was consistent with chronic inflammatory insult. FFA was done, which showed multiple pinpoint areas of leakage near the disc and near the fovea, with late diffuse pooling of the dye in the subretinal space without the classic ink blot or smokestack pattern, supporting there is an inflammatory etiology. This is the FFA pictures. In the left eye, you can see there is multiple pinpoint leaks around the disc and few around the fovea. So I thought that there's something missing. So we reviewed all the systemic investigation that have been done by the rheumatologist and found that the ANCA testing was missing. See, we ordered the ANCA testing, which came out to be positive. Mainly the P ANCA was markedly elevated. So then we thought of a multidisciplinary approach in which a rheumatologist and pulmonologist was also there. And in the context of the asthma, eosinophilia, sinusitis, and the ANCA positivity, it led to the diagnosis of a eosinophilic granulomatosis with polyangiitis, which was earlier called as a Church-Strauss syndrome. So in this, rather more than the ophthalmologist, the other people actually had primary role to do. So he was started on a long-term immunosuppression of cyclophosphamide by the rheumatologist, and systemic corticosteroids are gradually tapered. After the induction phase of cyclophosphamide, it was changed to a safer alternative of mepolizumab as advised by the pulmonologist, which is mainly recommended in asthma-specific EGPA. So the patient has a 1.8 years of follow-up with us. There was no further recurrences till date. Final BCVA is 6 is N6 in right eye, 6.9 N6 in left eye. So EGPA is a rare ANCA-associated vasculitis. Ocular involvement is uncommon, particularly in pediatric patient. Multimodal imaging is a critical for accurate diagnosis. So whenever you are having a patient, specifically children with posterior scleritis, it is very essential to see his fundus, and they can actually present with inflammatory macula involving serous detachments, which can mimic like a CSR or other causes of macular edema. When there is recurrence, always try to do a complete systemic evaluation, including ANCA. Early recognition and timely systemic immunosuppression with a multidisciplinary approach can achieve complete visual recovery and prevent relapses in pediatric patients with ocular manifestations of EGPA. Thank you.
Thank you, Dr. Rakhi, for this excellent, very interesting, and very well worked up case. I now invite Dr. Natasha Radhakrishnan, who's a senior retina consultant and a UVA specialist at the Chaitanya Group of Hospitals, Rajagiri Hospitals, and Lissi Hospitals at Kochi, who's the discussant for this case.
Good evening to all. Very nice case, Rakhi. So I think I'll just summarize with a few take-home points from her case. The first and foremost thing is that, like in uveitis in children, scleritis in children is not to be taken lightly, and any scleritis in a child should be investigated. Now, having said that, more importantly, even in an adult, when we look at, if you look at the various causes of redness in the eye, if you are looking at a case of episcleritis, when the deep vessel congestion is not there and it is just a mild dilatation of the superficial conjunctival vessels, most of the time that can come without any underlying cause. But if you take series of scleritis, most of the time scleritis almost always has an underlying cause unless it is an infective scleritis. So first thing for us to do when we are faced with a case of scleritis is, one, is it anterior or is it posterior or is it both, like a panscleritis? Secondly, is it necrotizing scleritis or is it a non-necrotizing scleritis? These two things will give us a distinction between whether it is a more dangerous kind of scleritis or a less dangerous kind of scleritis. This can be seen in your clinical investigation and clinical examination. And investigation wise, one of the most important things that we need to do when we are dealing with scleritis is to look at, is it infective or non-infective? So the tips to say that it may be infective is, one is to look at whether the cornea is involved. Secondly, is to look at whether there is anything like an abscess that you're seeing. Is the nodular elevation, like, is there an area of whitening there or a yellowish area in the center that tells you that it's like an abscess, which might give you a clue regarding a tuberculous etiology or like a fungal etiology. So, and also, is it recurring in the same place again and again in spite of your steroids? So, although we say scleritis is very dangerous, most of the time everybody treats scleritis, we give steroids, it gets better. So but if you have a patient whom you're not able to taper the steroid, it keeps recurring in the same place, you must, and you have areas that look like either like an infectious base there, then you must always take a biopsy and rule out an infection. So a biopsy with a PCR and a microscopy and culture will surely give you whether there is any, like a nocardia or a fungus or a TB that is causing the scleritis. Now, a
INA metro station पे छोड़ दो.
necrotizing scleritis is almost always associated with a systemic cause. Posterior scleritis is almost always associated with a systemic cause. Bilateral scleritis also should be like give you a idea that you must investigate scleritis in children. You must investigate for a systemic cause. Now, most of the common associations of scleritis that we see are the rheumatoid arthritis, then vaginous granulomatosis when it is a necrotizing scleritis, and sometimes you can get sclerouveitis in other conditions also. Church-Strauss per se in Rakhi's case is not been described in many cases because Church-Strauss is actually a kind of variant of what we call when it is vaginous granulomatosis, it is with the vasculitis with polyangiitis, and when it becomes granulomatous vasculitis with polyangiitis, and if it becomes a eosinophilic inflammation, then it becomes Churg-Strauss. So it can be considered as causing it by the same vasculitic mechanism that vaginous granulomatosis causes. But well spotted, and it's always important to look at the patient as a whole and look at the history as a whole, and especially when you're dealing with a recurrent case of scleritis. So that is the summary from my side. If anybody has any questions, I'll be happy.
Thank you, Dr. Natasha. Very well summed up. So, chairpersons, is there anything that you'd like to add?
Can I add something?
Yes, sir.
First of all, let me compliment Raki and also Natasha for the wonderful talk and also the nice discussion as well. What is important for everybody to understand is that please don't underestimate scleritis. You can get away with episcleritis or even uveitis anterior uveitis for the matter.
Correct.
Scleritis and posterior scleritis, you have to literally go all the way to find out what is causing. Especially when the patient is having a recurrent scleritis, it's really a dangerous thing.
यहीं छोड़ दो ना
Yeah, something which
आगे से मोड़ ही रहे हैं
which is very, very important for you to understand this ball game. And autoimmune disease, apart from that, the EGPA is something. I have a similar patient. Just last week, I'm treating the patient with the oral steroids. Initially, I gave him IV methadone because he is about 80 kgs now, that boy. He's about 14 years. And IV methadone followed by oral steroids. Now, as I taper the oral steroid, I'm planning to start the cyclophosphamide or azothioprine for this particular patient. But we have investigated completely. But I think EGPA is something which is very, very rare, but you have to keep that in the back of your mind. And really hats off to you, Raki, for bringing out this really rare but significant. It is significant from the point of view
Thank
of
you,
the
sir.
patient and the patient as well as the eye, as well as the life. Yeah. Did you take an ENT opinion for this patient?
So for sinusitis, he was having recurrent episodes of sinusitis. So for sinusitis, they had actually consulted and a nearby ENT. So with them, that MRI and CT scans, multiple CT scans were there. So sinuses were always inflamed in this child.
In this child. So he had a chronic allergy. So
Yes.
that was the base, and so that is one of the basis for the entire thing problem to occur as well.
Thank you, sir.
Yeah.
Only a couple of pearls. Don't start steroids till you have investigated, because then you might miss out on some investigations.
Absolutely.
And fungal infection is a rare thing which presents or mimics like a scleritis. We recently had a case which fulminantly went on for years until a biopsy was done to pick up a fungus from a lesion, which was an extensive scleritis. So I think that is one important thing. And one important point from the youngster's point of view, Wegener's name is now being dissociated from the condition because of the fact of his history, including Nazi thoughts and Nazi ideology. So that's the reason why that name is no longer associated with GPA.
GPA.
That was something we didn't know.
Yes.
Okay. So should we move on to the second case? We'll move on to the second case now. Our presenter is Dr. Namrata Kabra, who's a senior consultant in the Department of Cornea and Refractive Surgery at the Lakshmi Eye Institute, Mumbai. So Dr. Namrata has some interesting cornea cases, and looking forward to your talk.
Good evening, everyone, and thank you, Tinku ma'am. Thank you, ARC, AIOS. Thank you, Dr. Raki, for setting up the stage. In fact, I would like to reiterate and take this further, as Dr. Mohan Rajan sir said, don't underestimate sclera. Don't underestimate cornea as well, I would like to say. Let's begin with our first case. This was lady in her 60s and presented to us with relapsing red eye. She had multiple consultations over the period of 2 years, repeated treatments, flare-ups, and when she presented to us, the picture was something similar to this: epithelial defect, inflamed surface, irregular surface, and whatnot. On deeper or on keen examination, what we found was slap epithelium. Along with that, cornea shell shortening, and symblepharon. You can see near medial canthal area, there is symblepharon. Surface, as I already said, was inflamed, and limbal thickening, initial keratinization changes. Putting everything together, we diagnosed this case as presumed ocular cicatricial pemphigoid. We started with topical and systemic steroids, referred her to rheumatologist where mycophenolate mephitil was initiated, and she resolved. The resolution pictures are as clean as this. Later on, she is on maintenance therapy with cyclosporine eye drops and lubricants topically. So once cornea is also window for systemic diseases. Do not miss it and try to pick those clues. So in this case, the clue was typical telltale sign was symblepharon in elderly lady. Later on, this lady was doing fine and there were minor flare-ups. Whenever there is minor flare-ups, please go and dig deeper. She reduced the dose of mycophenolate mephitil on her own. So we could dig out the history. On digging out the history, we referred back to rheumatologist and informed him that she is not taking full dose, whatever you have prescribed. She was on 2 tablets twice a day. Instead of that, she reduced it to 1.5. So let rheumatologist be your follow friend. A second message I wanted to share. Again, the similar case 2, a senior doctor with persistent epiphora with mild congestion on and off, was suffering from this condition, consulted multiple ophthalmologists, and then underwent punctal snip operation for so-called diagnosed case of punctal stenosis, no relief. Again, punctal recanalization happened. Patient presented to us, we biopsied and confirmed OCP on histopathology. This patient responded very well to methotrexate. We were feeling wow, but here comes the real twist. Patient was on with gliptins. And after a couple of months, we realized gliptins, and then at that point of time, literature was published by other other ophthalmologists from western part of the world that gliptins can very well cause drug-induced cicatricial conjunctivitis. We discontinued gliptins and requested physician to start with some other oral OHAs, and patient resolved. Methotrexate was discontinued and patient is doing fine. So do not miss history part of it, especially when it comes to drug-induced cicatricial conjunctivitis. This patient presented to us with dry eye, SPKs, inflammation, filaments, as you can see, and couple of questions. Is there any history of joint pain, emotional tearing? Is there any history of dryness of mouth? And we could figure out this is going towards rheumatoid arthritis. Referred this patient to rheumatologist and started with ophthalmic treatment as well. Patient is doing fine. So cornea is a window for systemic diseases. Very well. Is it that it's only a window for systemic diseases? No. It also gives you clue for other diseases. This patient presented to us with non-resolving epithelial defect. And when we everted the lid, we got to see the triradiate horn, which was transparent one. We removed it and patient resolved. This was one of the interesting case where patient presented with conjunctivitis non-resolving. This patient has been referred to us for treatment. We could see the cornea as well. And the moment
Dr. Namrata, your voice is breaking.
From patient did well. So just to sum up, I would like to say elderly suspect OCP. Drug history is very, very important. And non-healing defect, search for a cause, not a drop. Do not miss lid examination, especially everted one whenever and wherever possible. And look through cornea and not just at cornea, because it can solve mysteries trivial to complicated, lid to surface, and also is a window to systemic diseases. Thank you. Thank you, everyone.
Thank you, Dr. Namrata. Very, very interesting cases indeed, and very well summed up and very good take-home messages. So now I invite our discussant, cornea expert, Dr. Meena Lakshmipati. Dr. Meena is a senior cornea consultant at the Shankar Nethralaya, Chennai. And Dr. Meena, looking forward to your comments on this case.
Thank you, Tinku, and hello, Namrata. Nice 3 cases on highlighting.
Ma'am is also one of my mentor when I was at Shankar Nethralaya. I'm happy to have her as a mentor.
No. I hardly did anything. So you highlighted a condition which is very devastating and very difficult to diagnose. And the first case was actually the hallmark of the case was the patient having visited many centers. So this is how they present. No, they're diagnosed as aqueous deficient dry eye, and they go to place. So the simple thing is to have an entire ocular examination, avert the lids and look for any signs of subtarsal fibrosis, and look at the depth of the lower fornix. Typically, the depth of the lower fornix is 11 millimeter from the inferior part of the limbus, and a minimum Foster classification of shortening of the fornix can be found out. So serial photographs is generally advocated when you see these patients continuously and look for shortening of the fornix, which means that the disease is progressing continuously. You obviously didn't do a biopsy, and biopsy is not mandatory according to the protocol of 2002. And whenever patients present with medial canthal shortening with a keratinization in that zone, along with fornicial shortening, it can be assumed as a case of OCP. What else you could do was to just shine a torchlight into the oral cavity, because it is now no longer known as OCP, it is known as mucous membrane pemphigoid. So these patients should be asked for history of pemphigus lesions, like recurring in the oral and in the genital part of the body. So that actually adds on to your criteria for diagnosis of OCP. So earlier there was a stepladder approach in the management, starting from dapsone to sulfasalazine, and then progressing to azathioprine or methotrexate. Now, since mycophenolate has proved its efficacy in safety, probably mycophenolate has become the first drug of choice. But mycophenolate is given 1,000 to 2,000 milligram per in a day, and generally it is not stopped. And your patient obviously had poor compliance, thinking that she was doing very well. So also your patient had persistent epithelial defects. Something like a preservative-free drops should be advocated for these patients. And cyclosporin, liftigraft and all have very little role to play, because this is a systemic disease, and only to control cytokines, there is some role of cyclosporin. So predominantly it's a disease, although it occurs ocularly, treatment is systemic to control the disease. Since it's not the epithelium which is involved, it is actually the deeper part of the conjunctiva, which is the lamina densa, which is involved, and to reach that area, only systemic treatment is advocated. And the other disease where there was a doctor, right, who again was misdiagnosed, underwent punctal cautery. Punctal cautery has been advocated as a method.
Underwent punctal snip rather than punctal cautery.
Because it had already stenosed and it had undergone. Yes. So this typically happens, and generally puncta is not touched in OCP because they get fibrosed, and you need that amount of fibrosis to increase the tear film height. Any intervention ocularly, especially trying to release the symblepharon or deepen the fornix, can exacerbate this condition. So all this interventions to improve the ocular surface have to be done when the patient is absolutely symptom free and not when they're having a disease. Even electroepilation can exacerbate the symptoms, and that is why it is advocated to just epilate the ectropion inducing persistent epithelial defects. And the gliptins is, I rarely see patients with gliptins induced OCP, and maybe you truly highlighted a very important message to the diabetologist as well, because gliptins has overtaken
Yes, ma'am.
I think the market as being the
It's
first line of
widely
therapy.
used these days, and
Yeah.
as an ophthalmologist, we should be aware of this. I thought, let me
Yes,
share.
yeah, but
my-
along with the drug, you should always look at the other signs, the telltale signs of uh, oral and genital lesions,
Mental.
because they have to be referred to the
Yeah.
specialist for treatment of these conditions. We will not be able to take these patients forward with these problems, because these are lifestyle modifications that the patient has to undergo. So I think the take-home message is probably the safe drug is mycophenolate. Topical drugs have very little role other than uh, lubricants, especially preservative-free lubricants, some amount of cyclosporin, and plasma-rich agents which have epidermal growth factors also help in epithelializing the cornea.
Thank
And
you.
biopsy should be done when possible.
Thank you, Dr. Meena. Some very
So
insightful
much, ma'am.
points that you highlighted. Thank you so much, both of you, for your inputs. And with that, we move to the chairpersons. So,
I
Dr.
think, Namrata, it's been an eye-opening talk. Though it's a very, very simple thing, I think we should not miss. And many of us, don't even look at the ocular surface properly. And even before the cataract surgery, I think it's very important to look at the fornix, look at the cornea, and look in very, very much detail and spend a lot of time on these patients. And so many things can be diagnosed, as you rightly said. And Meena, lovely discussion, Meena, on all these things. And non-healing defects. What is the role of liftigrast? I wanted to just ask you two questions. One is that, and another is, how does gliptin cause this OCP? What is the mechanism of action?
For lipidograph, it prevents ICAM handshake with the other molecule on T lymphocytes, and that's how it prevents further trigger of release of cytokine storm from T lymphocytes. So it's said that it has little different mechanism of action as compared to cyclosporin and tacrolimus,
Yeah.
and works better in case of acute inflammation or scar formation. And for chronic inflammation, cyclosporin and tacrolimus still holds the better option. Of course, we are still in the process of understanding lipidograph in detail, but whatever current research and current papers published based on that, and I would like Meena ma'am to add
Meena's,
on.
Meena's opinion on this.
Liftigraft is usually for very minimal role in OCP. It's generally ICAM prevention, and ICAM cannot be subsided by
What
this
about
cytokine. There's so much of cytokine storm in OCP. So that is why I didn't mention liftigraft. Maybe it can be an adjuvant therapy, but never the mainstay of treatment. Gliptins have some kind of T lymphocyte activation. Its mechanism is not really known. And T lymphocyte, when it gets activated, the CD4 counts are activated, and that's when the autoimmune antibodies start proliferating, and then they get deposited at the basement membrane. So its thing is not really very thing, but they have a specific protein inducing antibody. So the area of oculocicatricial pemphigoid basement membrane are plenty, but they are deeper in the lamina densa region. And in one of those places, you have hemidesmosomes, and they have multiple ligands over there. So gliptins actually cause an autoantibody against one of these proteins binding areas.
Thank you.
Just to
Any
clarify, sir.
the other chairpersons, anything, Dr. Natarajan, Dr. Grover, before we move on? Should we move on to the next, please? Dr. Natarajan?
Nothing. We can go to the next.
Yeah.
Go to the next
Okay.
one. Yes.
We'll go to the next one. So our next presenter is Dr.
Can you stop sharing this one?
Yeah, Dr. Namrata. Yeah, you can stop sharing your presentation, please. Dr. Namrata. So we'll go on to our next presenter, and that's Dr. Megha G, who's a consultant in the glaucoma services at Arvind Eye Hospital, Salem. And she has some interesting glaucoma cases. Dr. Megha.
Hello, ma'am. Is my slide visible?
No, not as yet. Have you
Not
shared?
Yeah, 1 second. I'll just share it again. What about now?
Yes.
Yeah.
Yeah. You could make it full screen, Dr.
Yes,
Megha.
ma'am. Unlike the previous two presenters who actually discussed some complex cases which were tough nut to crack, I'm going to present something which is probably common and all general ophthalmologists have to know. I've titled it as the paradox of pressure. So, 66-year-old male came with a sudden painless diminution of vision in right eye for the past 7 days, and in the left eye from past 2 years. He had no other associated complaints. However, he was a known diabetic and hypertensive. On examination, his vision was in the range of 6/60 to 5/60 in both eyes with normal intraocular pressures. His anterior segment showed RAPD in the right eye with PCIOL, and the left eye showed a brown cataract. The fundus examination, however, showed inferior retinal detachment in the right eye, and the B scan confirmed the same, and the left eye was normal. So a diagnosis of rhegmatogenous retinal detachment was made, for which he underwent belt buckling, PPV with silicone oil injection and endo laser. Prone position was advised. Routine post-op medications, which included topical steroids and antibiotics, and a tablet testozolamide BD for 5 days was given. However, on post-op day 1, his pressure shot up in both the eyes, with being 40 and 36 in right and left eye respectively, with chemosis, shallow anterior chamber, and closed angles. So as you can see, the left eye with the brown cataract, the vision has dropped further. So a glaucoma referral was done, wherein and the B scan showed that the right eye showed oil-filled globe, left eye showed shallow CDs. So a differential diagnosis in the right eye were probably related to the RD surgery, and in the left eye, considering choroidal detachment with shallow AC and high intraocular pressure, differentials of VKH, UL effusion syndrome, and sympathetic ophthalmia were considered, but all of them were ruled out clinically. So a probable diagnosis of bilateral secondary angle closure was done. LPI peripheral iodotomy and was not done due to CDs and inflammation. Topical brimonidine and timolol was given, netarsudil was given, tablet testozolamide was continued since his pressures were high, and both eye NSAIDs were also started, and rest of the post-op medications in the right eye were continued. But by post-op day 2, his symptoms and signs were even more severe. The chemosis increased, the anterior chamber was more shallower, and the IOP shot up to almost 50. So this is, the investigation showed the worsening of the CDs in the left eye. So this was how it looked on POD1 and then POD2. So the glaucoma senior was consulted, and when the diagnosis was revised, and now it was found to be oral estrozolamide induced acute secondary angle closure, and that's the name. That's hence the title, that some drug which is supposed to actually decrease the intraocular pressure has increased the intraocular pressure. So the tablet estrozolamide was discontinued immediately. The rest of the drugs were continued. And by post-op day 3, his eye pressure started dropping and left eye, in fact, became almost normal to 17. The chemosis had reduced, however, the anterior chamber still remained shallow. So on investigations, the left eye CDs still persisted. So he was discharged with topical brimonidine in right eye, timolol in both eyes, and advised to review after 5 days. So by post-op day 13, his intraocular pressures were normal, chemosis had reduced, his anterior chamber depth was also better, and the investigation showed that the left eye B scan showed that the left eye CDs had resolved, and his topical AGMs were continued. By post-op day 13, his IOP was fully normal, anterior chamber also was normal, and the gonioscopy was open. And by 3 weeks, everything was resolved, and he was not on any AGM, and still the pressures were normal. So what's different? Even though this is not very uncommon, it can easily be missed, and it's a idiosyncratic reaction to estezolamide. Usually we see topiramate-induced angle closures. However, we never suspect estezolamide to be the culprit. And it's causing paradoxical simultaneous bilateral acute angle closure due to choroidal effusion. So there are various causes for secondary angle closures, with drugs being the most common ones. So it can cause either by pupillary block mechanism or through idiosyncrasy. And how I'll just show a small animation for this. So idiosyncratic reaction to the drug causes sudden breakdown of the blood aqueous barrier, which causes vitreous dehydration that further causes expansion of the extravascular tissue of ciliary body. And this is what causes a ciliary body edema. And this ciliary body edema, how this causes angle closure is ciliary body swelling and ciliary choroidal effusion leads to anterior rotation of the ciliary body, which leads to forward displacement of the iris lens diaphragm and causes the acute angle at closure. And this forward displacement also causes zonular tension, decreases and thickening of the lens. Then that causes a myopic shift as well. So the management is timely withdrawal of the offending agent, topical alpha agonists and beta blockers. Cycloplegics also may be of role in some cases. Topical and systemic steroids have to be given. Do remember, no YAC-PI in this, and myotics have to be avoided. So let's reflect. It's a strange paradox. Drug which is used to treat raised IOP ended up causing the same. So there is a fine line between acute primary angle closure and acute secondary angle closure, and pilocarpine and LPI, which are the treatment for APAC, has to be avoided in this. And patient education about warning symptoms is a must, and early identification can prevent vision-threatening sequelae. So these are my references. Thank you, Dr. Tinku ma'am, and AIOS ARC for this opportunity.
Thank you, Dr. Megha. Very unique and interesting case indeed. I don't think we've ever heard or seen such a case. So now I invite the discussant, Dr. Mayuri Khamar. Dr. Mayuri Khamar, ma'am, is a senior glaucoma consultant at the Ocura Eye Care and Research Center. She's also been an ex-associate professor at the MNJ Institute of Ophthalmology at Ahmedabad. And she is a very senior glaucoma specialist and has over 37 years of experience in the field. So Dr. Mayuri Khamar, ma'am.
Thank you, Tinku. Megha, it was very interesting, though very rare case. The most important thing here is acute onset of bilateral angle closure. So most of the time, primary acute angle closure is a rarity. So one has to suspect the systemic cause here. Secondly, it is the post-surgical, particularly retinal detachment surgery done with the silicone oil injection. If it would have been unilateral, I would have suspected other reasons. But here it was bilateral. So the systemic drug acetazolamide is the culprit here. One should remember that when you have a bilateral acute onset disease, the mechanism should be understood well. It could be posterior pushing mechanism or anterior pulling mechanism. And this could be seen even with the microspherophakia cases or some other systemic syndromes like Well-Murchesani syndromes, or even after general anesthesia. Bilateral acute angle closure is possible. And most importantly, myopia, induced myopia in these particular cases. We see a lot of cases of topiramate, but the one you saw after surgery, so the first thing is everyone is giving tablet acetazolamide post-operatively. the buckle and the increase in the volume can also cause the angle closure, but it is bilateral. That is why it is acetazolamide. So nicely presented by you. If it would have been unilateral, non-surgical, then there are multiple causes like post-traumatic or inflammation is the main reason, or sometimes neovascular glaucoma or the sudden iris pigment release that can also induce this, and phacomorphic cases. You are right. These are the cases where nobody should do laser iridectomy or the pilocarpine is to be avoided. These are glaucoma inversus kind of thing. So very nice take home message. One should keep an eye on these type of glaucoma cases. Thank you.
Thank you, ma'am. Thank you for those excellent pointers. So moving on to the chairpersons. Sir, any inputs?
Yeah, can I make a comment, Tinku?
Yes, sir.
Mega, it was very nice. In fact, 1987, I published along with Dr. Sridhar Rao. Mayuri and Natarajan will know who Sridhar Rao is, an authority of glaucoma, wherein the patient had Bactrim DS, which is sulfonamide. So he had sulfonamide-induced bilateral angle closure attack. Okay, at that time we published this and he also reported this. The first time ever, wherein we found out patient similarly came like this only, similar picture to what you had, and bilateral angle closure glaucoma we had, and the patient was treated, and once we stopped that and treated the patient, become all right. So similarly, I think we have during the COVID time also, some unknown drug, I'm not sure what it is, some drug which we gave. We had 2 cases of bilateral angle closure glaucoma. Some IV was given for COVID. I don't remember what drug was there. Year 2020, I think, and the patient developed bilateral angle closure glaucoma, and we were not able, because the patient had multiple drugs. We were not able to pinpoint what exactly the drug was causing this, but it was not definitely Diamox. So it's not only Diamox, but also some other drugs can also cause this. The sulfonamide, because Diamox is also a sulfur group as well. Did you put the patient on atropine?
No, sir, since it already resolved with topical steroids, and we were very skeptical to put a cycloplegic in before confirming the diagnosis. But with steroids and stopping the drug itself,
high
it
dose of
resolved.
steroid and atropine will help you in faster resolution.
Yeah, because atropine will pull it back again.
Yes, it will pull these zonules.
These zonules back.
Yes.
It works very well for these patients.
Yes.
Yes.
Thank you. Thank you, sir. Any of the other chairpersons would like to comment? Any inputs or before we move on? So we'll move on then to the next case. So the next case is being presented by Dr. Jigna Motwane, who is a fellow in pediatric ophthalmology, strabismus and neuro-ophthalmology services at the LV Prasad Eye Institute, Hyderabad. So over to you, Dr. Jigna. She'll be telling us a new and innovative surgery for esotropia.
Thank you, Doctor. I hope my slides are visible and
yes,
clearly audible. Good evening to all panelists and attendees. Thank you, Dr. Tinku Bali and AIOS ARC and Dr. Vivek for giving me this opportunity. I would like to talk today about an intriguing surgery that redefines strabismus surgeries for large angle squints, and we would like to put it out for our general ophthalmologists. It is titled True Muscle Transplantation for Severe Esotropia. We had a 23-year-old male presenting to us with inward deviation of eyes since birth. His old photos showed esotropia since 1 year of age. He had no history of use of glasses and no other positive history of neurological symptoms. On further probing, he had an uneventful birth history. His visual acuity was 20 by 20 in both eyes, with a normal color vision, but a poor stereopsis of worse than 400 seconds of arc for near, and a small refractive error of compound hyperopic astigmatism in both eyes. On examination, he had no abnormal head posture and a fixation preference of the right eye with an esotropia of 35 degrees on Hirschberg test. The anterior segment examination and fundus examination were within normal limits in both eyes. On cover test, esotropia of 65 prism diopters was noted for distance and 70 prism diopters for near, which was checked with loose prisms by splitting in both eyes, with an inferior oblique overaction was noted with full and free ocular movements in all directions. He was diagnosed as infantile esotropia, which was long-standing and had a strong cross-fixation. The patient was keen on strabismus surgery for his left eye. Our surgical options to tackle such a large angle esotropia were either a bilateral medial rectus recession with a left eye lateral rectus resection, or a true muscle transplantation, or a hemi hangback recession with resection. True muscle transplantation is a surgical procedure where we use the resected part of the muscle as an alternate to allograft. It has proven to show fewer complications and better results regarding biocompatibility, availability, safety, and cost. As an alternate for supramaximal recession resection surgery, transplantation, wherein the resected muscle segment is sutured to the disinserted end of the recessed muscle, provides a large surgical correction. To reiterate, AB is the amount of recession and BC is the transplanted graft from the resected muscle. We planned the patient for a 6 millimeter medial rectus recession with a 10.5 millimeter lateral rectus recession with a 6 to 7 millimeter resected muscle transplantation to the medial rectus. These are a few surgical indications for such a transplantation procedure apart from patients with thin scleras such as in glaucoma or high myopia. To describe the procedure with a small surgical video, we hook the lateral rectus first and perform the resection procedure. We dissect the muscle very entirely, tag the muscle after measuring how much amount of resection is to be done. We tag the inserted end as well. After tagging both the ends, we mark the superior end of the muscle, measure the amount of transplant graft, cauterize the muscle, disinsert it from the insertion first, and then separate the graft tissue, which was 6 to 7 in our case. We inserted the muscle, the resected muscle, at the insertion site. We kept the grafted muscle separately with the two ends clearly visible. On the other end, we first disinserted the medial rectus, placed the graft with the superior end, tagged the muscle with the medial rectus muscle, made sure the ends are well sutured. After our elongated muscle was well adhered, we recessed 6 behind the original insertion, the elongated new muscle. Ultimately, we well sutured the conjunctiva and made sure there was no wound gain. We saw excellent outcomes in our patient, where on post-op day 1, he had some residual esotropia, but on follow-up at 1 month, we saw just a flick ET and no diplopia on follow-up. And or even on a long-term follow-up of 4 years, the patient had no palpable fissure changes, no duction limitation, and on cover test, he was orthotropia for distance and near. This was our patient preoperatively and postoperatively on long-term follow-up. A few advantages of this true muscle transplantation, which give us good postoperative alignment with no lateral incompetence, no diplopia, and helps to avoid surgery on a sound or habitually fixating eye with no significant change in palpebral fissure or globe retraction. The standard surgical doses have been mentioned in various articles, and our in-house study for such procedure have shown good outcomes. However, suboptimal results were noted in large angle exotropia. Ultimately, this is a procedure with good long-term outcomes, especially useful in large angle squints, causing minimal motility, limitation, and palpable fissure changes, giving good results for our patients. Thank you.
Thank you. Thank you, Dr. Jigna, for that very innovative surgery. And now I invite Dr. Vivek Varkad to discuss this case. Dr. Vivek Varkad is a consultant in the pediatric ophthalmology, strabismus, neuro-ophthalmology services at the LVPAI Bhubaneswar. So, Dr. Varkad, over to you.
Yeah, so thank you, Dr. Bali, for this wonderful opportunity, and thanks, Jigna, for putting this case here at National Forum. I think what she has described is use of true muscle transplantation. So we call it as a TMT in patients with extra large angle strabismus, maybe esotropia, exotropia, or even people have used, in resurgeries. So basically, this is kind of, the revisited or renewed interest that has been developed in this technique, which was being described almost 5 decades ago by Dr. Hayat. So it's been now popularized in India by, the first time when Dr. Amitava, he has published his extra large XT patients with very good outcome. So we have also our own experience of, using this technique for infantile esotropia and even those patients who had already had surgery. So you can use TMT in patients with resurgeries. So this technique gives a very good outcome in terms of, without compromising the palpebral fissure height changes as well as the reduction limitations. In terms of the technique is concerned, we are just using, that resected segment which we normally throw, to utilize it to lengthen the size of the muscle, lengthen the muscle which we want to recess without affecting the duction. So basically, we are not going beyond the range of normal R&R in terms of recession. So that helps us to keep the palpebral fissure height changes normal. And what is the fate of this particular transplanted segment? Over a period of time, it becomes a fibrous band and it gives strength to the muscle to whom, we attach this resected segment. I would be more than happy to take questions from other panelists and chairperson, or if there are anything in the chat box.
Dr.
Thank you,
Vivek,
Dr.
how do you
Bhaskar.
explain the success to be greater in esotropia than in exotropia?
Yeah, so basically, we have found in our own experience, because in exotropia, we have a limited amount of medial rectus to be resected. You cannot go beyond, 6 or 7 millimeter, contrary to, LR, which is like you can go as much as 10 and 12. So overall, if you see the published literature, it gives good outcome, although in exotropias, there is a suboptimal outcome. But now in my practice, I have started resecting little more, even without compromising, the kind of a retraction of the globe. So I go sometimes 7.5 if I want to tackle little larger XT.
The recession being larger than 7.5 or 8. I mean, 8 is not so unusual for lateral rectus.
No, 10.5 does, no?
10.5, you said.
10.5.
No, I said for MR, for XT, you need to resect the medial rectus.
No,
Yeah,
no.
how much
So
recession of lateral rectus did you say you would do?
yeah, you can do a recession of a lateral rectus as per the the standard norms. You can go as much as 9, 10, doesn't matter.
Beyond 8 or beyond up to 10 or so. Right.
Yes, which is beyond the range where we would not get the duction limitations.
Right.
Okay.
Can I just make a quick comment, Tinku?
Yes, sir.
Igna, really fantastic presentation, new concept. I'm not sure whether it's a new concept, but I do a lot of squint surgeries as well. But in this case, I would have done straight away bimedial recession and LR resection in the affected. I think it was a left eye, no? Yeah. So I would have done that as well. But this is, I think, is a very good. What is the what do you call the viability of this transposed muscle?
Yeah, so that's what this is a very interesting question. Dr. Hayat has described almost 5 decades back. He has done histopathological examination of this segment when he had an opportunity. So this is the slide which I was anticipating this question, and I had an opportunity to actually redo the surgery in the same eye. Although this another patient who had a sensory strabismus, and then I explored it again too, and now I am calling it as a double muscle transplant. Jigna, can you show that? So this segment becomes, the fibrous stand. So this is how one of my patient where we had looked at histopathologically, and at the end of day, this is a kind of not a true muscle tissue, rather it is a fibrous tissue. Although at the junction of true muscle and fibrous tissue, there are a lot of RBCs. So probably that keeps the junction viable and effective.
Okay, very, very nice.
Thank you.
Thank you,
Very
Dr.
nice.
So we now move on to our next presentation. Thank you for that very innovative surgery, something very new and interesting. And thank you, Dr. Jigna. Thank you, Dr. Varkad. And
Thank
now we move on to our next presenter. Our next presenter is Dr. Devakant Mishra, who is the director and head of the retina services at the Swarn Jyoti Eye Hospital in Lucknow. Dr. Devakant is also the very dynamic president of the Young Ophthalmologist Society of India, and under his leadership, it's gone from strength to strength. So he'll be presenting an interesting case of a scleral fixated IOL in an aniridic eye. Over to you, Dr. Devakant.
Thank you so much, Tinku ma'am, and the whole ARC team for this opportunity. So I'll be talking about, the scleral fixated IOLs in an aniridic eye. I'll straight away jump to the video. So we had a case of a young male who had a trauma history and then landed up with FAK and aniridia, presenting us with 660 vision.
Hello. हाँ मैं अभी जा रही हूँ.
So yeah, so this is now the challenge was when we started the case, we made our corneal, the scleral flaps and the scleral tunnel. And when we opened the box, we realized that both the haptics were missing. So it was a very disappointing situation. We had to postpone the surgery, get the guys to bring us another IOL for the IOL power. We didn't have it in the stock, of course. Now, when we started doing, probably after 2 weeks or so, when we re-posted the patient, we landed up in a similar situation. Now, one haptic was there, but the other was missing. So, uh, you know, but eventually the team was able to see. So we postponed the case again, and we were able to grab an IOL with both the haptics intact. So when we started the actual case, eventually, then we just reopened the scleral pockets, which we had made at 180-degree apart, and the scleral tunnel. Now, in my scleral fixated SFILs, the suture ones, I prefer 90 Prolene, and I use a 30 gauge needle to dock the straight needle of the 9O Prolene, and it is brought out from a scleral pocket on the opposite side. With the help of a straight or a curved forceps, we carefully bring it outside. Similarly, the other end of the straight needle is also brought out. Now I like using an ILM forceps to bring out both the sutures outside. Any other similar forceps can be used. Now we extract the whole length of the suture outside, and this is the IOL. I'm glad with both the haptics intact. We cut the suture right in between. Now there are various techniques to do this. This is my preferred technique, and I then the eyelet that is there in the haptic. The end of the suture, the cut end of the suture is brought inside and tied. Usually, when I do these cases, I ask my assistant to hold on to the lens of the to make it more stable. Otherwise, it becomes a difficult job. But with this IOL, I was a bit unsure because it once before what has happened to me is that I have broken a haptic on the table while my assistant was grabbing it. So I prefer to struggle a bit rather than involving the assistant in grabbing the haptic or the optic in this case. So we have to take care to make these sutures very proper, and once it is done on the this side, similarly it will be done on the other side as well, and the sutures are cut to appropriate length. The other thing that we need to understand is that it is a very large optic, almost 9 millimeters, and we need a pretty large tunnel. So I realized that my tunnel is small, so I went ahead and enlarged it a bit. We have to be careful that we don't cut the sutures while trying to do this maneuver. So it's important to understand that it's a very large optic because it needs to play the role of the iris as well. So very carefully we have to insert this IOL inside, and while inserting we have to take out the sutures from both the ends so that they don't get caught in the haptic. And now we can use this. The sutures are cut on both the ends, and we tie them. At this time, we can in this can be utilized to titrate and centrate the IOL at this time. So we do this suturing. What I do is that I just make the sutures tight at one end and then go ahead and finish the suturing on the other side and then come back to this side so that if any titration needs to be done in terms of centration can be done at that moment. So another important step at this after completing tying these knots is to bury these knots. Initially, it should be located at the position that it should be within the scleral pocket. And with the help of the spatula, very gently in a sweeping fashion, we can put these loose ends of the knot inside the pocket because otherwise it will cause erosion and will irritate the patient for the rest of his life. So that is pretty much it. This is at the end of the case, and that's day one post-operatively. So there were few learnings from these cases. One is never trust the box. So with these cases where you probably don't have these lenses tagged in your library, it's always wise before you block the patient to look at the lens and if it is intact or not. Another option, of course, not in this case, is aniridia rings. But that is when you have a bag. But I've used these also, and these are also very fragile. So you have to be very careful with them. Another debate is between a proline. I prefer a 9O proline over a 10O proline because it gives more strength. The other option is a Gore-Tex. I haven't used it, but my colleagues tell it gives more strength and is more long lasting, and it's easy to maneuver as well. These ninoprolines come in straight needle and a curved needle. I prefer a straight needle, but in case you get hold of a curved needle, you just need to bring the straight needle side from the other end and complete the case similarly. Yes, it's a very large optic, so the tunnel has to be of adequate size, and the optic haptic junction I feel is fragile and should be handled with care. And there are high chances, of course, in these NRED cases of secondary glaucoma. So long-term follow-up is very important in these cases. So thank you so much.
Thank you, Dr. Devakant, for showing us different thing. And for this, we have Dr. Sunil, who is Secretary of the Karnataka Ophthalmic Association. Sunil, sir.
Yeah, Devakant, excellent practical tips and an excellent video. I would like to add a couple of points to what you told. The first thing is, since it's being a trauma case, there is always a risk of hypotony. So you have to maintain the globe volume either by, as you shown, by using an infusion cannula or by an AC maintainer. The second thing, these PMMA haptics are quite fragile, so it can get broken very easily. So one should very carefully handle this PMMA haptics especially. The second thing is, as you told, the optic diameter is quite large, is 9 to 10 mm. So you need to have an adequate self-sealed tunnel. So preferably, you extended the tunnel intraoperatively also, but preferably for beginners, I would say keep a tunnel length of 10 mm, 9 to 10 millimeters self-sealed tunnel before you pass on the sutures. The second thing is, the main problem with the proline sutures, as you rightly told, is the knot exposure. Sometimes if you don't bury it, the suture degradation, late dislocation, many things can happen. But if you're comfortable with the Gore-Tex suture, definitely the long lasting and the stability of the IOL is much better with the Gore-Tex suture when compared to the proline sutures. The 90 proline, as you told, is the preferred proline technique. You showed the technique of either a scleral glue or a scleral flap. The other thing probably one can consider for the suture prevention of suture or a knot exposure is you can do an Hoffman pockets. If you do an Hoffman pockets, the suture gets buried within the Hoffman pockets. So the chances of knot exposure and other things will be less. Preferably, one should do a 4-point fixation rather than the 2-point fixation. For the simple reason, the stability of the IOL will be quite good. The most common problem which we face with the scleral fixated IOLs is the IOL tilt. So 4-point fixation prevents this chances of more of the IOL tilt and other things. Another practical tip with using an NRD IOL is try to go a little bit posterior as much as possible rather than anterior, because the PMMA haptics can rub against the rudimentary iris tissue or the trabecular meshwork, and can that itself can cause an glaucoma in a long term. And always keep a watch on the aniridia associated problems, like aniridia associated keratopathy could be there, aniridia associated glaucoma could be there. So sometimes the rudimentary iris tissue can cause a peripheral fibrosis also. So all these things should be kept in mind. And since you showed a case of a total aniridia, I totally accept with the management. And you showed about the peripheral, the prosthetic iris devices also, which are more comes with sometimes with an CTR, with an iris segments and all. That works well in the cases of a partial aniridia rather than a complete aniridia. So aniridia management itself is a challenging, but one should look and plan the surgically accordingly. Don't compromise with your tunnels and handle the sutures and the IOL very carefully, because it's a very fragile and can get broken very easily. That's all I would like to add. Some of the practical points.
Thank you. Before I invite Dr. Nupur, I would like to take a brief comment from Professor Natarajan sir.
Devakant, I think this aniridia is always a challenge.
Yes.
Broken the lenses, it's a real problem because the junction of the haptic and the optic, it breaks there. And normally I order about two or two lenses, and sometimes both of them, as you rightly said, both of them are broken. So the thing is, I think, as Sunil rightly said, we need to have a large incision, okay, and make sure that when you introduce the lens inside, there's absolutely no stress on any tissue, because if you have any stress on any tissue, the haptic will start folding and it will break. So the haptic is so fragile in this, and once the haptic is broken, the entire battle is lost. So otherwise, I think all the other techniques, whatever you have shown, is perfectly fine. Beautiful techniques you have shown, and I've started using Gore-Tex now, and for all the scleral fixation, which works wonderfully well as well. I think 90 Prolene is also very nice, very nice stability of the lenses. And only thing is, the long term, some patients have done about 10 years back or 5 years back, the blanching of the pigment occurs with these IOCAR lenses, Sometimes you have to be, because the constant rubbing of the iris and all the pigment gets released, and the blanching of the pigment gets, as I say, we can't do anything about it as well. Yes.
Yes, sir. Natarajan sir?
No, I think everything is well covered. And what was the follow-up you have, Devakant?
So now almost 6 months follow-up, sir. And
I think very good. Very good. Okay. The only lesson is probably you have to have backup lenses, which is the problem, and the cost also.
Yeah.
The backup lenses. You need to have another backup for backup.
Thank you.
Backup.
Can
Still
I
we are
add?
not sure.
I think the only point I'll add is, as Rajan said, you will have the challenges associated with aniridia itself. So you have to always be on the vigil for those either congenital aniridia, and then post-traumatic ones also have their own issues. So you have to be very careful with all those associated things that can happen over a period of time in the follow-up.
Yeah.
Thank you, sir. Thank you.
Now, prosthetic iris, Devakant, prosthetic iris, we can actually suture it to the prosthetic iris, no?
Yes,
Yeah,
sir.
yes. He showed, sir, both that we are the image he showed actually. The prosthetic iris with the IOL, you can club it actually if you want.
Yeah,
Yes.
you'll club it.
Dr. Deepak, can I add one comment?
Yes, sir. Yes, sir. Yes, sir.
It was a
Dr.
great video, Dr. D.K. Mishra. I enjoyed the way you had done. As a pediatric ophthalmologist, we do come across cataract in an iridia, and then, we usually prefer to, if you do a natural, the cataract surgery, lens aspiration, and keep, 4 millimeter ACC and 4 millimeter PPC, you would naturally end up with forming, the white donut-like, 360-degree circular rim. So that becomes, that makes the patient very, asymptomatic post-operatively in terms of, the photophobia. So I think that is a kind of, the artificial, although the natural way of creating the what you have showed, the 360-degree black ring, And I would say the central white part was little larger size. I think it's a 6 to 7, which might be still can cause photophobia to the patient.
It's pretty large, and of course, in our case, when the patient came to us, it was aniridic and had FAQs as well. So we had to opt for. But yeah, it's a beautiful option that you've told.
Actually, if you look at the Marshall aniridae IOLs, there are small optic central clear. Yeah, the aniridae IOLs are so preferably. What standard ones comes with a 5 mm central clear zone. You can have a smaller ones also if you are so concerned about the photophobia and other things.
Thank you.
What Vivek is told is something which we also follow, wherein you have a slightly smaller rexis, and the capsular fibrosis actually acts like an iris there. So the fibrosis which takes place in the capsule, that also can be done. Yes.
Okay, sir, we can take discussion later on. Now, our next speaker is Dr. Nupur Goyal. She is the consultant anterior segment and oculoplasty at Eye Care Hospital and PG Institute, Noida. Dr. Nupur, please.
So, a very good evening, everyone. I hope I'm audible and my slides are visible.
Yes.
Yeah,
Both.
so at the outset, I would like to thank the whole team, AIOS, ARC, Dr. Prashant Bavankule sir, Dr. Tinku ma'am, and Dr. Deepak sir for giving me the opportunity to present. So before we start, so what happens when you do a sac syringing? So either it is patent or there is regurgitation. So remember this slide and we move on. So today we are presenting there is something secret and mysterious which is going to happen. Syringe is secret. Where did the fluid go? So I'm Dr. Nupur, consultant anterior segment oculoplasty surgeon at Eye Care Eye Hospital, Noida. So this was a routine case of sac syringing in a patient with epiphoria who came for a preoperative clearance for cataract surgery. So after injecting the fluid in the lacrimal sac, as we've already discussed in the first slide, we expect one of the two outcomes. Either the syringing would be patent, that means the patient would feel the fluid in the throat or the nose, or there would be a regurgitation of injected fluid in either punctum. To make it clear, let's have a look at this diagrams. As you can see, when you inject the fluid, the yellow color is the lacrimal fluid, and this is the when you syringe. So either it will go in the nose or the throat if the syringing is patent, or if there's any blockage, the fluid would regurgitate. But in this case, something else happened. So let's have a look at the video. So the syringing is being done, and when we're injecting the fluid, so what we saw that there was neither regurgitation nor did the patient fluid feel any fluid in the throat. So there was the syringing was not patent and there was no regurgitation. So here we come to what was the secret, what is the syringe's secret, and where did this fluid actually go? So what did we do next? So we went ahead and did this Ropla's regurgitation pressure of lacrimal sac, and we saw that the fluid actually regurgitated. So this is where, so the mystery was solved. What we were dealing with the case of atonic lacrimal sac. So what is an atonic lacrimal sac? The lacrimal sac actually gets dilated and loses its tonicity. So it's not able to pump the fluid out through the nasolacrimal duct. And hence the syringing was not patent. And neither there was regurgitation because of the loss of the tonicity of the lacrimal sac. But when you do the syringing, there is fluid filled in the lacrimal sac. So when you apply pressure, there is regurgitation or pressure of lacrimal sac. So we know that the source of infection is always the lacrimal sac fluid, and this in the case of atonic sac, there is a lacrimal fluid stasis. Hence, this patient could not be given a clearance for cataract surgery and needs a DCR surgery or management of the lacrimal sac before we actually proceed with the intraocular surgery. So one thing which I also want to elucidate with this is also the correct method of checking the Roplas or the regurgitation or pressure in lacrimal sac. It is important to know the exact position of the lacrimal sac, which is in the lacrimal fossa, as you can see. So this needs to be known well before you do this maneuver. So the take-home message is that atonic sac, one should be aware of the condition and the management, and always repeat the Roplas once you do the syringing, because so that you don't miss out on the condition of atonic sac. So thank you.
Absolutely marvelous, Nupur. Superb, really.
Thank you.
Yeah.
Thank you, Dr. Nupur.
Yeah.
So,
comment, Doel.
Any discussant?
Yeah. Discussant is Dr. Amrita.
Yeah, let's have.
She is the consultant at Sir Ganga Ram Hospital, New Delhi. Dr. Amrita, please.
Yes, good evening, Nupur. Very well presented. And thank you very much for bringing up such a relevant topic. I think it is still very, very commonly missed. And another thing is, syringing is important. Even in cases of intermittent epiphora, you must ask the history how many times you dab in a day. So patients will tell you more than 5 times, more than 10 times. So do not shy away from doing syringing. And equally more important is to do it correctly and to interpret the results. So, sometimes we've seen people are syringing with, broken 26 gauge needles, which should be stopped. I feel they should use proper lacrimal cannulas. Proper syringes should be used. And the technique is also equally important. I'm sure it was out of the scope of this presentation. It was difficult. But again, how to stretch the lid while you're inserting the cannula. And you should never over push. If you feel there is resistance, you should stop. Otherwise, you can create false passages, is also very important. And as far as interpretation is concerned, you've actually mentioned quite a few important things. But again, just to repeat a little bit of this very few tips, that if there is a clear fluid immediately regurgitating from the opposite punctum, then we know that it's a common canalicular blockage. And if there is a delayed regurgitation with mucus flakes, then we are thinking in terms of nasolacrimal duct. However, in this case, like you mentioned, that there was neither regurgitation nor it was going into the throat, but there was a medial canthal swelling, whereas this patient had no Rho+ negative before that. That is important because in atonic sac, you can also press the sac and you can have the fluid going into the throat. So it's not necessary that the fluid will actually regurgitate onto the ocular surface. So that is also very important and one of the differentiating points from nasolacrimal duct obstruction that I would like to highlight. And also in this video, which you presented very well, the second video where you press the sac, there was only clear fluid coming out of the sac. So when the regurgitation is because of nasolacrimal duct obstruction, which may be having an atonic sac, then it is usually filled with mucus because it is already lax for a very long time and there is chronic dacrocystitis which is happening there. So I think these are the very, very important things. And in case you're still interested in differentiating between atonic sac and NLDO, then sure shot is dacrocystography that you can perform, which will actually show whether the passage is clear or not. But ultimately, I think patient has to undergo dacrocystorhinostomy procedure if they need cataract. And also, I would like to highlight in cases of corneal ulcers, it is very, very important to syringe and to perform the surgery because that could be one of the main causes. Yeah.
Thank you, ma'am. Thank you.
Dr. Nupur. Any comments?
There is one request from the Dr. Namendu that he's going, since we are running late and he's going to attend some function. So if chairpersons allow, then I will change the
Maybe
order
after
and
one single comment, which is to
Yes, yes,
emphasize
sir, after,
once again the importance of learning syringing very well. Syringing is a full chapter, and syringing should always be accompanied by diagnostic probing. That is very vital to your correct diagnosis, which is not something that is regularly taught. The diagnostic probing tells you all the differentials for lacrimal obstruction, and you should always be with a forceps so that you can see how much did the probe traverse and with a scale. And all these three tools should always be available, and they are vital to giving you the right diagnosis. As about the atonic sac, this is something which must be known as an entity because this is a source of pus, as much of a nuisance as a proper acquired nasolacrimal duct obstruction, without at times any obstruction being elicited on syringing, because syringing is a forceful procedure. So with an atonic sac, if you push really well, you would get the fluid going into the nose, but you would also get a swollen sac, which you can see, and from which Nupur so beautifully showed, you can get back a fluid regurgitation. So it is important to know this entity of atonic sac and diagnose them in all those cases where there is a history of discharge, even if syringing is patent. Of course, you have the Jones dye test to see a functional obstruction, and even more physiological than DCG is dacroscintigraphy. If you have a Giga-Muller counter and you put a dye, then you are totally putting the fluid in a normal physiological way to allow it to go through the passage rather than pushing it as in decrocystography. So all those tools are available for you to pick up a functional obstruction, upper system functional and sacs atonic. You need to pick up those two entities as well.
Thank you, sir. So next is Dr. Navendu Rai. He is the chief VR surgeon at the Dr. Navendu's Hospital at Devariya and editor UP Journal of Ophthalmology. Dr. Navendu, please, since we are running slightly late, so we request everyone to be on the time.
You are muted, Navendu.
Sorry.
Yes.
A very good evening, Narayan sir, my mentor, Narayan sir, Rajan sir, Grover sir, Deepak boss.
Yes, sir. Good evening.
Very much. Thank you, sir. Thank you very much, sir. Good evening, sir. Thank you very much for giving me this opportunity to present an interesting case in front of this August gathering. And I will be speaking on a case of metal hole formation after giving bevacizumab. So this is a 48-year-old male who is diabetic and hypertensive for last 15 years, and he came to me with the diminution of vision for 1 year. So he had, you can see the fundus findings from the photographs, and the OCT, you can see you can very well visualize the massive CME that this patient has. So I had advised him for, it's not moving. Yes. So I advised him for intravitreal anti-VEGF, and Avastin was given in both the eyes in a gap of 1 week. The right eye, it responded well, and after 2 doses of Avastin, there was a considerable amount of fluid that was washed out from the macula. But in the left eye, to my surprise, there was some elevation seen after 3 weeks of Avastin. And on observation, in another almost 1 month, a macular hole was seen in this case. So what next? The right eye was a modified grid laser was done for this patient, and the patient responded very well. It improved, the vision improved from 3 meters to 618 in the right eye. While the left eye, in spite of going for any intervention, I observed that patient, and the fluid again accumulated. And this time there was a considerable amount of CME and SRF in this patient. So the second dose of Avastin was given. And to my surprise, there was a similar photograph after 3 weeks of giving the second dose of bevacizumab. And on observation for 1 month, again a macular hole was seen, which was even worse prognostically in this case after second dose of Avastin. So what next? I planned for a vitrectomy in this case, ILM peeling, 25 years vitrectomy with William Blue assisted ILM peeling was done. And this patient responded well. There was a type 1 closure of macular hole in this case. So what points that I would like to emphasize from this case are there are some rare complications that should be kept in mind with the use of anti-VEGF agents. And macular hole has been associated with anti-VEGF use in patients of CNVM. But this was the first time then that I could see a macular hole in a patient with DME. The second dose could have been skipped, and macular hole surgery could have been done after the first dose of TVEGF itself, that I could retrospectively think of, because after the first dose, the macular hole was in a better shape as the second one. And visual prognosis in such case, macular hole cases is usually not good. This patient could improve from, there was no improvement in the vision because he even before the any of the treatment, the patient was speaking out in 3 meters, and after surgery, the patient was only speaking out in 3 meters. So this is what I would like to tell you all, and thank you very much. And I'm also standing for the post of member of scientific committee. Please do vote for me. Thank you.
Thank you, Dr. Navendu. So the discussant is Dr. Aditi. Dr. Aditi is consultant at Narayan Nethralaya. Dr. Aditi.
Muted.
Dr. Aditi,
Thank
kindly
you,
unmute.
Dr. Deepak Mishra, sir, and good evening, all. Thank you, Dr. Navendu Rai, sir, for beautifully demonstrating this case with a rare complication of macular hole following anti-VEGF injection, here bevacizumab. Well, let's start with what could have caused macular hole following anti-VEGF injections. Firstly, there can be acute changes in the vitreous dynamics, especially when there is a pre-existing, problems with the vitreomacular interface.
Yeah.
And so that can lead to all these vitreomacular interface changes, acute probable PVD induction or an anomalous PVD. Secondly, sometimes when the fluid also dries up quickly, all those large foveal cysts that you showed in your first OCT, that can also collapse. And you may have such a picture. You also mentioned that you then went on to give a second injection. Well, sometimes you can, debate it both ways. Giving a second injection again led to a macular hole, but it also sometimes dries up the macular edema, makes your peel also easier for the surgery, if you look at it that way. So it's common with anti-VEGFs in DME also, though it's more commonly seen in neovascular AMDs, where you can have the contraction of the fibrovascular membrane, and especially in these kind of cases when the retina is diseased, unlike like an idiopathic macular hole, there are various challenges, and one must look at all the characteristics of the vitreomacular interface with the edema that may have caused to this may have led to this rare complication of macular hole in your case.
Thank you, Dr. Aditi. So
Deepak, can I
yes,
add?
sir, yes, sir. Please,
No,
sir. Please, sir.
one more thing is you mentioned the macular edema was there for almost a year with multiple cysts. So I think in cases with branch vein and central vein, we can see patients who have chronic macular edema where they are not checked at all. That can produce macular hole, and maybe I feel this being a chronic macular edema, and you gave the Avastin probably added to it. Even if you have not given the anti-VEGF, maybe this patient would have got a macular hole. So I think, definitely we have to keep this in mind. And anyway, I think as you rightly said, after the first injection, you could have probably done the macular hole surgery.
Thank you, sir. Thank you.
Thank you, sir.
Next is Dr. Nilesh Kumar. He is the medical director at Madhvi Netralaya, Ara, Bihar, and also the secretary of Young Ophthalmic Association, YOSI of the India. Dr. Nilesh, please.
Thank you so much, sir. Thank you, Deepak, sir, for this introduction, and thank you, Tinku, ma'am, for including me in this session, and thank you, ARC. Uh, I am going to talk about Botrop-based breakthrough for pterygium graft fixation. So these are the commercially available preparation of Botrop-based, that is hemocoagulase, that is derived from Botrop-based snake. And these are commonly used in dental surgeries, gynec surgeries, and even in general surgeries for homeostasis. So the person who was the medical representative was behind my life to use it in DCR cases. So he had given me few samples, and then suddenly one trauma case, and it was a very clean cut. So I thought that for hemostasis, I used just a few drops of Botropase, and the bleeding stopped. And then I used the tissue glue to do a sutureless the wound fixation. And with this, the patient cosmesis was very good. And then another case came where there was a very disfiguring laceration. And in this case also, I did the same thing. What I did is just use Botro paste to achieve hemostasis. And after that, I just pasted with the tissue glue. And you can see after 4 weeks, the patient also used the Botro paste along with mixing with Neosporin ointment over the wound through the 4 week. And you can see how beautifully the scar has healed without even using a single, I think only one or two sutures I used here and there, and the wound has healed very beautifully. Then I used it in DCR, and in DCR, what I saw was a fibrin stand forming when I was removing the clot, and that gave me that is it acting as a fibrin glue. And then I started studying more about it, and then what I found out that what it does is actually it converts fibrinogen to fibrin monomer and thrombin-like action, and also enhances the clot stabilization. So it gives two things. It not only gives good graft fixation, but also it helps in the wound healing and rapid graft adhesion. So then I started to, I thought that let's use it in pterygium graft fixation. So this is the first of the surgery of this kind that was done, and it is a routine case of a grade 2 pterygium, nasal pterygium, and I am just doing the sub conjunctival dissection to remove the pterygium tissue from below the conjunctiva, making sure that the nasal rectus is not uh, damaged. And then I put one drop of water paste, and what it does is it reduces the amount of graft that is needed because it sticks the conjunctiva and covers the Barrett's sclera. And now you can see I just raise a subtenous free conjunctival graft, autograft on the superior limbus, and I try to undermine it a little bit so that I get a little bit of limbal cells there. Once the graft is raised, I avulse the pterygium head and do a pterygiorhexis, and after that I spread the pterygium graft over the Barrett's sclera. And as you can see, when I will lift this graft to put one more drop of water base below it, the fibrin start to form already. Like this is in real time, and within like 30 seconds, the pterygium, the fibrin stand starts forming. So you can see it is very sticky already. But you don't. If you make the sclera bone dry, then this won't work. It is not a replacement of fibrin glue. It requires little bit of ooze to work. Without that, it won't work. So then I thought, can I use it for amniotic membrane, wet amniotic membrane as well? Because it doesn't matter what I'm going to stick it until I have some amount of oozing below. So then I thought that let's try in a case of wet amniotic membrane. So this is another case of a pterygium, again grade 2, that is encroaching to the pupil. Little atrophic, so not too much of subconjunctival tissue that is available. Some subtenous dissection as well, and I remove it. As you can see, I cut the wet amniotic membrane to size, and then spread it over the cornea. That is my preferred technique, and then slide it over to the conjunctiva, and then trim it to the required size. So it goes again below, and you can see a little bit of ooze is there below the tissue. Now I'll trim it to the side, trim it to size, and then I'll try to put some uh, butter paste below it. So now what I have done is I started loading it into 1 ml syringe and started using, rather than asking my assistant to pour it from the vial. And I discard the remaining vial. I don't use it for the next day, as it is very cheap. It's only 180 rupees. I do that. You can see I just pinch the vessels to create a little bit of ooze if the ooze is not there. You can do the same, and with this, I get the same amount of graft stability that I get with sutures. So I have started doing comparison study, and the results are going to be shown at AIOC uh, during the free paper presentation. But it shows similar efficacy and safety as fibrin glue, with similar kind of adherence that is there. Just make sure that you wipe out extra fluid, because there might be graft edema post that. This is day one post-op picture of the same patient. With this surgical technique is also published, and you can access the article through this QR code. Thank you for this opportunity.
Thank you, Dr. Nilesh, for showing the excellent videos. Now the discussant, I will going to invite Dr. Doyal Biswas. She is the consultant cataract and refractive surgery at Sushrut Eye Foundation, Kolkata. Dr. Biswas.
Thank you. Well, I'm supposed to be the discussant here for Nilesh, but the honest truth is that I have not done this surgery before. And I have actually heard of it just a few days back. And when I searched literature, I found that Nilesh is the only one who has done this or has, shown a video of it or written anything on it. So I am going to play the devil's advocate. I'm sorry, Nilesh. I have a little query actually. For one thing, you have said that, you cannot have that area bone dry. You need a little bit of oozing. So what I'm asking you is that how do you say that it is the botropase that is actually causing the graft to stick and not the ooze like we do in autologous blood? Because what do we do when we use autologous blood to put the uh, what is that called, the graft in place? It's the same oozing that we use. And I, for one, again, when I use autologous blood, I always clean that area first and then cause a little bit of oozing, not too much of oozing, because if there's too much of oozing, it pushes the graft up and then you have more chances of graft refraction. So a little amount of oozing and I put my graft and I iron it out. So what I'm asking you is that how does the botropase actually help in this? How is it any way different from the autologous blood that we are using?
Two things that I found it superior to autologous blood, ma'am. It requires oozing, so I can't deny the fact that it is not using the autologous blood. But the superiority lies in that it gives a rapid adhesion. So within 30 seconds, we start seeing the fibrin starts to form. So we might not need to wait for 2 or 3 minutes or 5 minutes, depending on what the clotting time is. We don't need to wait for that. And we have very many surgeons who are not as meticulous as you, ma'am. So they might not have that amount of patience to make it completely dry and then again induce a limited ooze. Those who have very high volume surgeries, in those cases, like they have 10 or 12 pterygium lined up. So in those cases, they can just put a drop of water paste. It will give the hemostasis, and then they wipe it off, put the graft, and again induce a little bit of ooze and one more drop of water paste. So it makes it very rapid. Second thing is the graft retraction, as you told. With autologous blood, if there is a lot of blood below that, it will cause clot retraction. But with this, the clot retraction is not there because it is making the clot very stable. So these are the two superiority point over it. But again, it requires the blood to be on the base, so I can't deny that fact at all.
What is the advantage
Thank
of
you.
fibrin glue, Nilesh?
So with the cost, sir, I there is
Only the cost.
fibrin glue is much superior than this, but the only
Yeah.
factor is it is 180 rupees, so very very cheap.
He's out
Also,
to put them
I
out
would
of
say,
business, right?
Ma'am, just
Want to
Doyle,
get the
ma'am, just to appraise you, there are around 12, 13 surgeons that are already using it in different centers, including one of the prominent user is Dr. Atul Kadne sir from Maharashtra and one Dr. Gaurav Gupta from Faridabad. So we are trying to pool the data and publish a multi-centric study soon.
Very nice.
Yeah, thanks.
I
Thank
have
you,
a
sir.
case,
So,
Nilesh, on Monday. I have a few cases, so I promise you I'm going to try this out this Monday itself.
Sure, ma'am. Thank you so
thank
much.
you, ma'am. Thank you.
That's a very
Next
nice
is,
duel.
Thank you, sir.
thank you. Next is Dr. Kaushik Tripathi. He's the consultant retina, uvea and cataract at ASG Hospital, Kolkata. Dr. Kaushik, please.
Thank you, Deepak sir, for the kind introduction. Thanks to the ARC team, Dr. Prathan Bhawankule sir, Dr. Tinku Bali ma'am, and Dr. Deepak Mishra sir, and all the AIOS leadership for having me here. So I'll just share a few cases in which retinal clues, retinal findings gave a clue to systemic issues. So I'll discuss a few vascular disorders, few neoplastic disorders, infections, and pediatric disorders. So this was a case, 21-year-old male who had bilateral dimness of vision, and the findings were similar. Both eye had this huge disc edema, corneal spots, and hemorrhage. So vision was 2/60. He was not taking any medications, and he did not have any other history. So when we checked the BP, it was 200 by 124 milliliter mercury. So the take-home point will be you have to check blood pressure in all cases with bilateral optic disc edema, specifically if they have this kind of like corneal spots. So this was a male who came for routine checkup, but on evaluation we found that on the bifurcation of the retinal arterial there was a shiny thing, which was an embolus. So he had good vision, but we got lipid profile, carotid Doppler, and echocardiography, and there was a large atheromatous plaque at the common carotid artery, and there was dyslipidemia in this patient. So this was a patient, 74-year-old male who had sudden dimness of vision, had hand movements vision. He had intraretinal hyperreflectivity in the inner retina, and there was feature suggestive of central retinal arterial occlusion. When we asked him more, he gave a history of pyoderma gangrenosum, which is an autoimmune disease. So my take-home point would be you have to take thorough history and rule out autoimmune diseases, vasculitis in CRO, along with obviously embolism. So this was a 25-year-old female who had bilateral dimness of vision, and findings were similar, both high preretinal, intraretinal hemorrhages and Roth spots. So we, because this was a textbook presentation, we had to rule out anemia, pancytopenia, and leukopenia in such a patient, and this patient had pancytopenia due to aplastic anemia. So this was a this was a girl, 13-year-old girl, who had this kind of lesions, and right eye had exudative retinal detachment. So because these were typical of retinal hemangioblastoma, we had to rule out von Hippel-Lindau disease. We had got MRI brain, and which showed cerebellar hemangioblastoma in this patient. And also you'll have to check the family, fundus features, and also other systemic features. So this was a lady. When we found, when we checked the fundus, there were angioid around the disc, and there was this typical orange peel appearance temporal to the macula. And when we saw the skin, there was this plucked chicken appearance on the neck. And this patient, the biopsy turned out to be pseudoxanthoma elasticum. So this was another female, 35-year-old female, who had yellowish lesion in the below the supratemporal retina. It was a large subretinal abscess, and when we checked the history, she had pulmonary tuberculosis, and on ATT and steroids, her lesions resolved beautifully. So this was a kid with this very minimal vitritis and typical lesions of CMV retinitis denoted by white retinitis lesions and hemorrhages. So when we checked her, she was already taking medications for leukemia, and she was HIV negative. So in CMV retinitis, you have to rule out immunosuppression. HIV is the commonest cause, but blood dyscrasias can also cause, and patients with immunosuppression can also have this kind of disease. So this was a rare patient, who 12-year-old male, who had recurrent seizures and frequent fall. The left eye had this kind of scar with radial pattern of pigment splitters, and there was hemorrhagic retinitis in the right eye. There were multiple DDs with the pediatrician, but this specifically left eye feature was very typical of SSP, and ultimately SSP was proven by CSF antibody to measles. This was a 40-year-old male who was HIV positive, and his vision was 6/18. A round kind of lesion was seen in the below the retina, a placoid lesion, and because this was very typical of acute syphilitic placoid choroiditinitis, we did the test, and he was confirmed to be have syphilis, and he improved drastically with penicillin. So this was another girl who had the height was short, and fundus features were similar in both the eyes. There were pigmentary changes, and there are extra digits in the extra fingers and extra toes. So this was typical of Bardet-Biedl syndrome. So the take-home point would be, in pigmentary retinopathy, you have to look for systemic diseases. So this is my last case. This lady had the diagnosis, had been carrying the diagnosis of ARMD, but she had typical wreath-like pattern of this thing, choroidal atrophy around the fovea, which is very typical of maternally inherited diabetes and deafness. So when we checked her mother, she also right images are of mother. So she also had similar features, which is more prominent in autofluorescence. So genetic testing confirmed maternally inherited diabetes and deafness, and both mother and daughter had diabetes and deafness. So thank you.
Thank you, Dr. Kaushik. And the best part is you have already added everything in the literature, means almost all your cases were already published. So the discussant is Dr. Charu Mittal ma'am. She is the principal consultant at Max Eye Care, Saket, New Delhi. Charu ma'am.
Thank you, ARC, Tinku ma'am, Dr. Deepak, for this opportunity. And I must compliment a wonderful bouquet of cases showing almost entire range of retinal conditions that we can have. And just the one point take home here is that retina is definitely the window to the systemic diseases, as is very well seen with all these cases here. And I've been working in a multi-speciality hospital. It is very important to and fro between the internist, the rheumatologist, and the ophthalmologist. We often see such cases which give a lot of clue regarding their systemic diseases and can be life-saving at times. patients with hypertension having scleritis and other issues also, nephropathy. Dr. Tripathi showed a wonderful array of cases. It's difficult to discuss all, but my only take home here would be that, yes, the retina evaluation is of utmost importance when patients are having systemic diseases along with the vision-related symptoms. And it's a both-way thing. With newer drugs, and even the internists are sending us patients for ruling out like these GLP-1 drugs, where we have to tell them whether they are at a risk of having ocular concerns and whether they should be started on these drugs and vice versa. Thank you.
Thank you. Thank you.
I think wonderful, Kaushik. They have published also, and I think one thing is important is I think we have to keep all this in the mind when you're seeing a patient, particularly it doesn't come into the normal features in the retina. So I think it's excellent. So what the mind does not know, eyes do not see. So you have to have this in the mind, and both of you are wonderful. I think wonderful cases.
I think this discussion would be incomplete unless we spoke about the gold mine that is in the offing. The AI with the retina is the gold mine of the future, predicting every vascular disease, including Alzheimer's, including coronary disease, including Parkinsonism, and everything. So, and the therapeutic effects will also be evaluated from the retinal changes. So, I think it's going to be one major area, because this is the only place where you can see vessels and see the subtle changes in the vessels which AI can pick up that we have so far not been able to clinically talk about. So I think a gold mine.
Also the wide angle cameras, sir. The wide angle cameras, I think it's a really a big boon in my
So
opinion.
even in the physician clinics nowadays, they are having the screening on a regular basis.
Yes.
And for diabetic retinopathy, we being the world capital, the AI is bringing out newer systems where we can screen people at a larger scale.
Yeah, that's right. Yes.
So next is Dr. Rolika Bansal. She is the consultant ocular oncology and oculoplasty at Mahatma Gandhi Medical College and Hospital at Jaipur, Rajasthan. Dr. Rolika, please.
Thank you, sir. And since I'm traveling, I just requested Nandita and Dr. Nupur to help me share my screen. I've recorded my presentation so that there's no patchy internet, but I'm online here as well. So Nandita, can you please share the screen?
Yes, ma'am. Just a minute, ma'am.
Thank you so much for this a thoughtful series of cases.
A very good evening, everyone. And I'm Dr. Rolika Bansal, and I thank the ARC team for giving me the opportunity to discuss our case of imaging the unseen and saving the seen. And it's a very interesting session that has been curated, and I'm glad to be a part of it. So our case presented as a 35-year-old male with diminution of vision in the left eye since 2 months, with history of on and off allergic cough, no history of lesions or swellings on the body, no history of weight loss, known diabetic since 2 years. And when we, kind of get caught into the depth of the case, we realized that 2 months back, this is the picture that the patient shared, with vision in the right eye of 6/6 and the left eye vision was 6/12, with no RAPD, and you can see a lesion over here, which could have been a possible choroidal hemangioma with retinal attachment by the looks of it, or an amelanotic melanoma. But this is what the patient was told and was asked to be observed. Now, at presentation to us, the patient had actually deteriorated. The left eye vision had dropped down to counting fingers close to face with RAPD grade 2. And you can see a small pigmented lesion in the right eye below the medial canthus and few nodular lesions over the chest on the right side. We're trying to be thorough with our workup. However, on the fundus examination, the picture had completely changed. There was a huge lesion, which was a diffuse lesion and extending from the superior to the inferior arcade. There was another small nodular lesion seen along the superior nasal arcade, and there was inferior retinal detachment, and there was even macular involvement. And as you can see, the differentials at this moment become choroidal amelanotic melanoma, granuloma, metastasis, lymphoma, or even a hemangioma. However, we must always look at the other eye, even though it was normal previously. The other eye also had multiple small lesions which were well defined, and a small inferior retinal detachment had started developing. So as we can see, the picture went from this all the way to this. That means in 2 months the patient has progressed, and therefore the differentials went down to metastasis and lymphoma only. Now we have to understand that this requires a multimodal imaging. That means we are trying to image the unseen, right? So this is what we looked at. So a USG or a B scan showed in the right eye the highest lesion was 3 mm, and in the left eye the highest lesion was 5.7 mm. So fluorescent angiography showed stippled appearance in the right and the left eye over the lesion, and there was inferior retinal detachment which can be seen. We also did OCT and OCT angiography. In the right eye, as you can see, the macula was clear, but SRF is kind of seeping towards the macula. And when we went through the lesion, we saw a typical seasick appearance over the lesion, through the lesion. That's the raster view. And then another view over here, as you can see, the left eye, the macula was involved, and there is a typical seasick appearance when we see it through the lesion. So keeping all these things in mind, we had a complete diagnosis of choroidal metastasis. But now this is imaging the unseen. What exactly is unseen in these cases? This is a lesion that you can already see. The unseen part is PET-CT. So when we did the PET-CT, the correct imaging, we realized that there is increased FDG uptake in choroid, lung, liver, right abdominal wall. And we were able to do this because we got an indication for possible choroidal metastasis because of the lesion that was seen in the eye. And as you can see, another case over here, this is a case of breast carcinoma with choroidal metastasis, which was treated with plaque brachytherapy here. And this is a case, again, of a moderately differentiated adenocarcinoma of the lung with choroidal metastasis and nodal hepatic skeleton and CNS involvement. Another case over here, which is a typical lesion seen in carcinoma lung, and the liver biopsy was atypical carcinoid. And another case over here, as seen, it was a case of thyroid with choroidal metastasis. So the points to be noted over here are that 8% of the cases of choroidal metastasis actually get diagnosed in autopsy. So it's very important to do a very thorough ophthalmic examination. And 33% of breast malignancies and 25% of lung malignancies present to the ophthalmologist first. So we are the first point of contact for them. Breast carcinoma is most common primary source in 40 to 53% cases, with 92% with systemic metastasis in presentation, and they're mostly post-equatorial in 89% cases and multifocal in 48% cases, as we have seen in our case as well. Choroidal metastasis appear late in the malignancy and are associated with disseminated disease and poor prognosis. And what do they present with? More often, blurred vision. So treatment modalities are available, and it's important. My message through this case is that please make sure that you notice these things, because it's all about attention to details. And if we know what we're looking at, we can actually save the scene by imaging the unseen, and that is, we should look out for the possibility of systemic metastasis in these cases. Thank you so much.
Thank you, Dr. Ulka.
Wonderful.
So our discussant is Dr. Seema Das, ma'am. She is the Director of Oculoplasty and Ocular Oncology Services at Saraf Charity Eye Hospital. Seema, ma'am, please.
Thank you, Dr. Deepak, and wonderful presentation, Rolika, and thank you very much for highlighting this, very important aspect, because these are the kind of lesion every ophthalmologist are going to see once in a while. Very inconspicuous looking small choroidal mass lesion. But sometimes it could be actually an indicator of a very underlying grave disease, and it's very important that it is picked up then and there rather than waiting for the things to progress, and in the process let the outcome become even more poorer. So as you rightly pointed it out that many of the METs can be just asymptomatic, and we do see patients where the ocular findings are the initial presentation, especially for the lung and the breast. And we are seeing a trend of increasing incidence of metastatic lung tumors, even in patients who are non-smoker, and even in female who probably never were smoker. So what is the underlying cause? We really don't know. Something to do with your, the kind of things we are inhaling or whatever it is. But we need to be extremely suspicious of any such kind of lesion if we see. Isolated circumscribed choroidal hemangioma, yes, those are also not something which is very uncommon. But most often than not, unless there is subretinal fluid, the patients are actually not symptomatic and they are just sometimes detected on a routine imaging. So if the patient has come with symptoms of and there is fluid, we have to be extremely suspicious and investigate that patient further and not just send them home, especially in younger patient. This might not be the age group also for the circumscribed hemangiomas. I think the picture that you have shown, the second picture, of course, is very obvious with so much of massive subretinal fluid. I think even before the multimodal imaging, in metastasis, the fluid always is disproportionate to the kind of, the size of the lesion. And that is always a clue. Extreme amount of subretinal fluid with a lesion which does not look that big is metastasis is something which always needs to be ruled out. Even in melanoma, unless it is necrotic, we hardly see subretinal fluid. Same for hemangioma. Even if it is there, the amount of fluid is not that much to cause a bullous detachment and so much of undulation. So yes, METS is something we have to be extremely cautious. If you're seeing a lot of subretinal fluid, which seems to be disproportionate to the size of the lesion, and in a smaller lesion, if we have access to the multimodal imaging, especially in OCT, because the OCT biomarkers, the characteristics are very typical of metastasis versus an hemangioma. A smooth choroidal dome-shaped lesion is what typically hemangioma look like. And as you showed, as you've kind of described, metastasis is always a very lumpy, bumpy appearance of the choroid. It's never a smooth dome-shaped lesion. And that's probably is the kind of, once we see a lesion, we really don't have to go for any further investigation and just go for the systemic workup of the patient to rule out an underlying malignancy. But yeah, very important thing which you have highlighted. And thanks for bringing out this point.
Beautiful.
Yeah.
Thank you, ma'am. I'll just add one more point, ma'am. You've absolutely completed the presentation now. And I would just say that with time, as the longevity has increased, we have studied that the number of years a patient lives after having a primary malignancy, it's more. And that increases the chances of a person developing a metastasis. So the longer a
Right.
patient lives, the higher is the chances of the patient getting metastasis. So, like I had a patient last week that 2015 she was treated with for breast carcinoma. Now she's lived 10 years already, and that is when now she has developed choroidal metastasis, which was indicative of a systemic metastasis, and that's why we could detect it. So now we will
Yeah.
see it more often. So we have
Yeah,
to keep it in
absolutely.
mind.
Absolutely, because they live
Very
longer.
true. Very true.
Right.
I think
So
that was a master class on intraocular tumors by Rolika and Seema. Really fantastic. Thank you very much.
Thank you, sir. Thank you, ma'am.
Very good.
Very nice, Rolika. Excellent. Dr. Deepak, could you call the next
yes,
speaker?
next is Dr. Pranesh Ravi. He's the consultant at Eye Foundation, Hosur. Dr. Ravi.
Thank you, sir. I'll share my slides.
I'm slightly cutting introduction of everything because there is slight delay so that we can complete it on the time because
Are my slides
we have
visible, sir?
two
Yes,
more.
Dr. Pranesh, they're visible.
Yes.
In the
Just
outset,
make
I'd
it
like to
full
thank
screen.
full screen is
Yeah.
full screen, sir?
Yes.
Yeah, in the outset, I'd like to thank Tinku ma'am and the esteemed chairpersons in this dais for giving me this opportunity. So I'll be presenting a topic of corneal tattooing where from blueprint to bedside, where I had a small hiccup and how I managed this case from laminar to superficial micropuncture. So this is a 32-year-old female who came with a blind eye, slightly moving towards phthisis and cosmetic disfigurement. She had tried a cosmetic contact lens, but owing to the conformity issues, she had a very poor fit and wanted a better cosmetic enhancement for her eye condition. So she had opted for tattooing. So it was a very endothelial compromised cornea. It had a thickness of 770. So I thought, why not try lamellar? Because of the corneal thickness and our IOP was a bit low. So I thought I would adjust to this using giving a block and slightly making the globe tense. So what I planned was making the globe tense, and then I'll use a guarded trephine of 350, slightly go in the deeper plane, create a pocket, and then deposit the carbon suit, which I'd already procured, and apply it. So that I chose this because this is, as far as longevity is concerned, the Lamela technique works better, and there is a low retreatment rate. So I thought I'll do this, but so for that I just inject an anesthetic to form the globe, I define the plane, and I executed. Then I thought of executing the dissection using a crescent blade. But unfortunately, I had a anterior perforation in this case, where I just misanticipated how soft the globe would be. I tried to dissect, and because of severe hypotony, the blade went through and through. So then I had mitigated this I just converted it into a superficial manual keratopigmentation and applied pigment directly to the anterior surface using a 26 gauge needle. Uh, so I'll show you a video of that. So this is me doing a partial thickness trephine using a guarded trephine, and then I thought I'll just start it with the crescent blade. I'm starting the dissection, and I'm not able to get a hold because eye is soft. So I'm just trying to move forward using wriggling movements. And then when I really try to insinuate myself into the stroma, I'm noticing a bit of thinning. I'm just trying to slightly change the plane, and then I have a punch through. So then I thought I'll move to the superficial keratopigmentation. Epithelial debridement is being done, and then I'm using a needle, trimming the blood in the area of this thing. I'm just using a needle to kind of. Actually, for this, I thought of applying drop wise, and I thought I'll use the bent bevel of the needle and move quadrant wise, so that I know what are the areas I treated, and then work around the areas where there are lesser pigmentation. And I'm using two needles in both my hands to that quicken my job, and giving equal pressure with both the hands. So I'm attacking a quadrant by quadrant, and then whichever areas are less pigmented, I'm just moving around. So I ensure even and proper impregnation of the pigment into the corneal stroma. So, and then finally, when I find that eye is adequately pigmented, then I apply a bandage contact lens and call it a day. So in the outset, these two techniques, this is a differentiation factorial. Even though the interlamellar had a low fading rate and was comparatively better compared to superficial manual pigmentation, in this case it was used as a rescue plan. Usually in corneas with scarring, or if there is thinning, in that cases superficial micropigmentation works. And if you are having a stable cornea where you can do a lamellar dissection, then interlamellar is the way to go. Thank you. Thank you for giving me the opportunity. Thank you very much.
Thank you for that excellent case. And now I invite our discussant, Dr. Kunjal Sechpal. Dr. Kunjal is a cataract, cornea, and refractive surgeon at the Vision Eye Care Center in Mumbai. And she has a lot of experience with corneal tattooing. So, Dr. Kunjal, what are your comments on this case?
Very good evening at the outset. Thank you, Dr. Tinku Bali and ARC, for making me a part of this wonderful webinar. Thank you, Dr. Pranesh. Actually, you brought about very important points that a simple procedure like tattoo can also land up with complications. And hence, every single step from the pre-op assessment to the planning is very crucial. Now, the first thing is that in a thiassical eye, generally, I would prefer not to advise a corneal tattooing, and I would like to motivate the patient to have a procedure like an evisceration ball implant. However, supposing you want to go ahead with a corneal tattooing procedure, there are a few points that you need to look at. First, you should counsel the patient that in future, if the eye becomes more thiassical, then it's not going to be because you did a procedure, but it's because maybe she has an RD or whatever. So that is the first thing. Second thing, if you know that the eyeball is soft, then you should be prepared with two options. If you have a clear cornea relatively with an anterior chamber view, like probably in your case, then you can inject fluid in the anterior chamber and make it tight, or you can take help of your retina colleague and ask them to inject silicone oil just before you start the procedure. So you can inject silicone oil first, and then you go ahead with your lamellar dissection. Supposing now you want to do a lamellar technique. As you said, there is a superficial technique option and a lamellar technique option. Definitely the lamellar technique is the preferred technique. But what I would really like to emphasize is that the lamellar technique is not required to be done as deep as you were describing. So you should just start at the limbus, just go 100 120 microns deeper, make a linear incision with a 50 number blade. Then you dissect the pocket with the crescent knife as you did, and complete the dissection with lamellar dissectors like you would do in a lamellar dissect surgery. And then you can use any die of your choice. So you don't need to use a guarded knife, and you do not need to go that deep. In fact, if you go that deep and the superficial cornea has a haze because of edema, then your effect of tattooing will appear much lighter than you would desire it to happen. Even if you go superficial, in a few years the effect is going to, the pigment does migrate deeper. So anyways, you're going to lose your effect. So it is very important to not go that deep. That's what I would emphasize. In your case, supposing you had the perforation that you had, you could have just sutured that side, and from another side done a much more superficial pocket, and just continued the lamellar dissection itself. And what you did is absolutely fine, but the needle technique doesn't really last long. So another better technique, if you want to do a superficial technique, would be to use the tattoo gun, or if you have access, to use gold or platinum chloride with hydrazine hydrate as your surface procedure. That is also a very good option.
Thank you very much.
Thank
Actually,
you, Dr.
I thought I had a lot of corneal thickness, so I thought I'll use a Trofine and guide go deeper. Even then, I couldn't insinuate it through the section, ma'am. Yeah, but I understand because I thought I was soft, so I thought I'll go a little deep to compensate for it. So, yeah, points. Thank you very much.
Pranesh,
Sir, sir.
you use a special gun like thing which puts the dye into the cornea, no? But you're
Yeah,
using
sir.
still.
No. I have a tattoo gun, sir, but the charge wasn't that sufficient, sir, so I did manually.
Okay.
So if you use a tattoo gun,
you have more control in that,
more better even pigmentation, sir.
Yeah.
So, but we always prefer, supposing there's an edematous cornea which does not have a superficial scar, we always prefer a lamellar pocket even over the gun. And we prefer the gun in cases where the scarring is, throughout the cornea, so that if you don't get a superficial pocket, if there's scar even in the superficial area, then the gun is the best way to do it, or the gold chloride technique.
Okay.
And this dye, Dr. Kunjal, how expensive is it?
So there are 3-4 options. You can use carbon soot as he intended to use. You can use a liquid dye, which with the tattoo people use for the skin. So supposing you're using the liquid dye, which is very easy to use, then the small bottle is barely 600 to 800 rupees. And that is the least quantity that you can get. But even if you buy like expensive brand, generally we use Dynamite brand, Intense brand. These are the common brands, Star Bright. These are the common brands which all of us use, and we can get it online, or we can buy it from a local tattoo supplier. So it doesn't even if you change the brand also, it doesn't cross 1,000 rupees. And you just need 2-3 drops. You're just going to waste the bottle, because we avoid reusing after a long gap.
Okay, thank you.
Yeah, thank you so much.
Chairpersons, any comments?
I think I've already given the comment. I think it's beautiful.
Okay, so we'll just move on.
Yeah.
So our next presenter is Dr. Nandita Trivedi. Dr. Nandita is a cornea fellow at the Arvind Eye Hospital, Madurai. And over to her.
Thank you so much, ma'am, for giving me this opportunity to present. Good evening, everyone. The topic for my discussion is PCR surgical salvage, recognize, respond, and rescue. As general ophthalmologists, cataract surgery forms the basic of our surgical journey. Every surgery is associated with its set of complications, and it is important to learn how to manage these complications. Human crystalline lens is enclosed in a thin capsular bag. Capsule is an elastic basement membrane which is thickest at the anterior and posterior pre-equatorial zones and thinnest at the central posterior pole. This thinness makes it vulnerable to rupture. There can be various causes for extension for PCR. One of it is extension of capsular rhexis margin. This is a case of an intumescent cataract in which capsular rhexis is being done. We can notice in the video that the tip of the needle is far away from the flap of the rhexis. And due to the intumescent, the rhexis got extended to the periphery. The surgeon tried to perform Little's maneuver, however, he wasn't able to retrieve the margin. Hence, reverse rhexis was being done. However, due to positive pressure from the intumescent cataract, the cataract got extended in the other direction as well. Now, how can we avoid this? In case of intumescent cataract, when we start with the rhexis, we can make a C-shaped incision so that it doesn't get extended to the periphery. We can go for double rhexis in which we make a smaller rhexis and we milk out the intumescent matter and then we further extend the rhexis. Rhexis can occur due to direct injury to the posterior capsule. This is a case of an NS2 with PSC with cortical cataract in which stop and chop technique was used for performing phacoemulsification. As we can see in the video, while doing epinuclear sheet removal, the phaco tip directly injured and caused punch injury in the punch hole in the PCR. It is important to note that phacoemulsification should be performed only in the safe central zone of 4 mm. PCR can also occur due to the inherent weakness of the capsule. This is a case of a central dense polar cataract in which an adequate size rhexis was made, after which hydrodelineation was done. And while doing epinuclear sheet removal, we noticed a pre-existing PCR defect. In cases of posterior polar cataract, it is important not to do hydrodissection and minimal rotation of the nucleus should be done. So if the PCR occurs, the next point is how do we manage the PCR? The first step is do not panic. Stabilize your anterior chamber with OVD prior to removing your phacotip. Early recognition of PCR is important. Look for indirect clues like sudden deepening of the chamber, momentary expansion of the pupil. Do not blindly fish the nucleus with the phacotip. The next is do not overinflate the globe with dispersive viscoelastic and use a separate irrigating cannula instead of a coaxial infusion. So this is a case, yeah. This is a case of NS2 with PSC with cortical cataract. While doing epinuclear sheath removal, the surgeon accidentally caused a PCR, and we can see in the video while trying to aspirate the last piece, there's loss of followability. The surgeon after this immediately took out the phacotip without injecting the viscoelastic. This further expanded the rent and caused more vitreous disturbance. Now, while doing vitrectomy, you change the settings to low aspiration and vacuum setting, lower the irrigating bottle, and maximize the cut rate. It is important to note to keep the vitrectomy tip under direct visualization at all times. To remove the cortical matter, after the complete thorough vitrectomy is done, we can then shift to IA cut mode. For aspirating out the loose cortical matter in the anterior chamber, we can use viscoexpression. Here, complete thorough vitrectomy has been done in cut IA mode. After which, since the rhexis margin was intact, we extended the main port incision and we put a non-foldable PMMA lens in the sulcus. After putting the lens in the sulcus, the stability of the IOL was noted. Since the IOL was stable, the main port was sutured, and after suturing the main port, diluted triamcinolone was put to look for any remnant vitreous in the AC. Since no vitreous strands were present, the side port and the main port were hydrated, and the case was closed. So, summarizing, if there's a PCR and if there's no vitreous loss, we see if there's soft nucleus and most of it is emulsified, we can proceed with phaco using generous amounts of OVD. However, if there's hard nucleus or large chunks remain, we can convert to ECC or MSICS. In case of vitreous loss, nuclear fragments should be moved superiorly to a safer zone using OVD. A thorough bimanual anterior vitrectomy has to be performed. I hope through this video discussion, I've been able to highlight a few of the mistakes that we make during our cataract surgery at some point in our surgical journey. And if we stay vigilant, we can recognize these complications at an early stage and better manage it. Thank you so much.
Thank you, Dr. Nandita, for having highlighted all these little tips so very well in your videos. And now I invite our discussant, Dr. Ruchika Agarwal. Dr. Ruchika is a professor and head of department at the Department of Ophthalmology at Rama Medical College, Kanpur.
Yes, a very good evening, everyone. And thank you, Dr. Tinku ARC, for giving me this opportunity. And congratulations to Dr. Nandita. She has captured almost all the points. But what I like to just add on or just, reinforce that PCR, first of all, it can be managed. We should be it's better to be prepare in advance. Like if we have some complicated cataracts like a PPC or a small pupil or a traumatic cataract, white or black. So we can anticipate, first of all, before the surgery that something like this going to be happen and we're going to be mentally prepared. And most important, second point is to recognize the PCR once it happens, because otherwise, if you don't recognize it, then the management, you won't be able to do the ideal management and you may increase the rent, or you might add on to the vitreous loss or drop some fragments into the vitreous. So after recognizing, if you've recognized, then the most important part is to stop the blame game. Rather yourself, the patient, the anatomy of the eye, the staff. So once you recognize the rent, you have to calm yourself and thinking something what has happened. Still, the patient can have good vision if you manage it properly. So that something has to be done. And that, as Dr. Nandita has showed, that one surgeon immediately the reflex is once you do a rent to take out your probe outside. So I think there should be, some kind of mock drill or something should be done. Like we say rent, and then your next step is to inject the visco and then lower the irrigation and take your probe out. The reflex immediately is rent and then you just take out thinking. So that reflex has to be, changed by doing some mock drill. I do with residents. You say rent and then the reflex is to take your probe out. So rather than that, the reflex has to be inject the dispersive so as to prevent the, enlarging of the rent or more loss of vitreous. Then recognizing we were talking about recognizing the signs that PCR has happened. So that sudden deepening of AC or dilatation of the pupil or peaking of the pupil, loss of followability. So these signs should be on your tips. And then whenever you see any of them, you should be able to recognize it. Then, depending upon your expertise, once you have taken your probe out and now you know which stage of operation you are, whether the nucleus is inside or still you are aspirating the cortex, and depending upon your expertise, you should handle the case. There's no harm in calling your seniors or if you are individually operating. So, first of all, you should be knowing your expertise, ki whether will you be able to handle this case or you need a help. So depending upon the situation, as she told, if there are smaller fragments, we can use lower phaco settings and we can safely further emulsify. Or if we feel these chunks are bigger, then we might convert. If it's happened during the uh, uh, cortex removal, so it's better to use a bimanual setting, because if you use a coaxial one, you are going to irrigate or hydrate the vitreous more, which will add on to the problems. And depending upon if you've done, you feel you are in the last stages, so you can implant a 3-piece or a sulcus lens as she has shown. So, and after doing a proper anterior vitrectomy, and yes, you should start using tricot while before closing, so that to make sure that none of the vitreous is left in the AC, which can damage your cornea. I think it's a big topic to be, discussed in a small. So I'm not sure have I gone through the
Through
You
way
everything.
it was supposed to
highlighted
be.
all the important points,
Can
Dr.
I make a
Ruchika.
comment,
Very well.
Tinku?
Very well. Yes, sir.
No, I think I don't know how many of you have seen my PCR 10 Commandments, which is out there in the
Yeah,
YouTube
yeah.
award-winning video. But all the points, whatever Nandita has told and whatever Ruchika has told us also is fine. But what is important is, of course, the risk factors for PCR, traumatic cataracts, post-vitrectomy, post-injections nowadays. All these patients we have to be very, very careful about it. Small pupils, pseudo exfoliation, brown cataracts, and posterior polar cataracts, of course. Most important thing is what Nandita told. The one thing I would tend to disagree is, as soon as you notice a PCR, put viscoat. Okay, put viscoat. The viscoat, what happens is the viscoat will go and plug that PC tear, and it go and plug, and only viscoat works very well because they disperse viscoelastic and very difficult to remove also. And then immediately you put tricot there. Okay, immediately put diluted tricot 1:3, because you don't want to remove the cortex or the nucleus in the presence of vitreous in the anterior chamber. And unless you put tricot there, at that time you have to put tricot, not at the end of after putting the lens. At that time you have to put tricot and make sure that you remove the vitreous first and then remove the new epinucleus or the nucleus, or you can even do a scaffold of the nucleus, bring the nucleus up into the iris, and then but remove the vitreous first and then put the IOL into the sulcus and then do the nucleus, the IOL scaffold. So that's what I would prefer. But without managing the vitreous, don't try to manage your nucleus or the epinucleus or the cortex. So, okay, and everything is bimanual, as you rightly said, separate the irrigation from the cutter, separate the irrigation from the aspiration. And don't go through the main port at all. Don't use the main port at all. So that's another important thing which I want to mention here. Okay?
Thank you, sir.
Yeah.
Dr. Grover, sir, anything that you would like to comment on? Sir, you're muted.
Is there?
I think what Raj Mohan said is very valuable. That any manipulation in the presence of vitreous is really a no-no, because that leads to all the traction and all the problems that take place. The second thing that I would like to emphasize is it is important to end up well. Because in the end, unless you have ensured a round regular pupil, made sure that small strands are no longer there, you've not done the job well. So triamcinolone is critical, and pilocarpine often is a very valuable tool in ensuring that you get that round regular pupil at the end.
Thank you, sir. Dr. Natarajan, sir. Dr. Natarajan, are you there? Dr. Natarajan, as a VR surgeon, what is your perspective on, a PCT or a nucleus drop? What are the things that you want to tell your anterior segment colleague?
So I always tell that the anterior segment surgeons, when they are doing practice, they should have, if they have a posterior segment surgeon in their own practice, then inform them, particularly the posterior polar cataract, traumatic cataract, or a post-injection or a post-vitrectomy, you expect PCR. But in case you are practicing alone and you're only a single surgeon, you always have a touch with tell them that you're posting. And if you have a dislocated lens, and I tell them not to meddle more,
Yes.
close the wound, and then send the patient. You always tell the patient that there's a risk which is there, and if you anticipate, you tell them that if in case there's a nucleus drop, we'll refer to the posterior segment surgeon, and then they can take it up. So that it's a pre-plan, so that you have a contingency plan, so that you don't panic. I think that's what both Dr. Nandita and Ruchika mentioned, not to get tense. But I think you should have a contingency plan. If this happens, what is next? And then if you have, don't back up. You already have talked to your person and make sure that the other surgeon is available in the town, so that they can refer the patient in time, so that they can manage the inflammation, the pressure before they refer.
Yeah.
Another important thing, Tinku, is that if you have PCR and if you got an intact rexis there, put the lens, three-piece lens into the sulcus. Don't leave it there. Just capture that optic into the capsular rexis margin. So this optic, when you capture it, what happens is the lens does not move a micron, number one, and also the lens is actually in the bag. The optic is in the bag, so there's no this thing of any UGH syndrome or anything like that. So I think this is another important thing. Always put a multi-piece and capture it in the bag.
Very well pointed out.
Only one proviso: make sure that your rexis margins are perfectly intact, because sometimes the PCR is an extension from a anterior rexis break.
Not sometimes. In fact, in our study, we found the most common reason for a PCR is an anterior capsular tear, which wraps around and goes. So I think it's very important. Many people underestimate that, but I think it's a very important anterior capsular tears which can go around, and especially when you're using femto, sir, you have to be a little careful. There can be
absolutely.
Yes, especially when you're
again, do make sure that your rexis is intact before you think about capturing the optic.
True. So thank you so much, and some very pertinent points were highlighted. And with that, we move on to our last talk of this webinar, and that will be by Dr. Ajinkya Deshmukh. Dr. Deshmukh is a consultant, squint pediatric and neuro-ophthalmology, and he works at the Prabha Eye Clinic and Research Center at Bangalore, and he has some interesting cases to show us. Dr. Ajinkya, over to you.
Good evening. Thank you so much, Dr. Tinku Bali and AIOS ARC for this wonderful opportunity. Am I audible and are my slides visible?
Yes, you're audible. Slides, you could make it full screen, Dr. Ajinkya.
Yeah. So my talk is on fiery and not so fiery fistulas. What if I tell you this and all of this is a spectrum of a similar disease? This is my first case of a 61-year-old lady who is a known hypertensive, and she had redness in her left eye for past 1 month, and she was prescribed, just a minute. So she was prescribed a topical antibiotic and lubricant eye drop elsewhere, with which she was not responding. Her uncorrected visual acuity was right eye 6 by 12 parts and left eye 6 by 24 parts with near vision of N6, and intraocular pressures were 18 millimeters of mercury. On extraocular motility examination, she had -2 limitation of elevation and depression in left eye, along with levo elevation and levo depression limitation. What was striking was this. There were these dilated, tortuous episcleral vessels on slit lamp examination, and there were no follicles or papillae suggestive of any sign of any infection or allergies. And this cleansed us to suspect a possible underlying etiology of keratico-cavernous fistula. So we imaged her and we could see there is enhancement in the left cavernous sinus along with this left superior ophthalmic vein dilatation, which confirmed the diagnosis of left keratico-cavernous fistula. And she was referred to the neurocenter for neurosurgical intervention. And on DSA scan, she was revealed to have left-sided type B Barrow CCF and underwent the carotid decompression. On 2 months follow-up, her diplopia had reduced, extraocular motility had improved, but her vision has dropped from 624 parts to 2 by 60. And as you can see, she had a disc edema and a uveitis, the inflammation in the eye, which was likely due to incompletely resolved CCF. And she was referred back to NIMHANS for possible coiling with or without stenting for a permanent cure of her CCF. This is a second case of an 83-year-old lady who had history of CS cervix status post chemoradiation in 2000. She was pseudophakic in both eyes, and she complained of occasional diplopia since few months. She has had ptosis in January 22 and was treated for possible third nerve palsy by a neurologist. Her extraocular motility revealed limited abduction, elevation, and adduction in right eye, and limited abduction in the left eye. Again, on slit lamp examination, we could see this dilated, tortuous episcleral vessels, again suspecting us to think of something to do with the brain. So we wanted to rule out keratico-cavernous fistula. And on imaging, we could see that there is dilatation of right-sided superior ophthalmic vein, as we can see in the axial and the coronal scan in the above two images, and bilateral enhancement in the cavernous sinus region. So she had a transfemoral DSA scan which confirmed bilateral CCF, and she underwent transvenous embolization of the CCF. But again, owing to her age, it was a tough road for her for the recovery post neurosurgery. So whenever the patient presents like this with multiple cranial nerve palsies, what are the usual differential diagnoses which we need to have in mind? So these are the 5 differential diagnoses we need to have: cavernous sinus syndrome, orbital apex syndrome, superior orbital fissure syndrome, ocular myasthenia, and trauma. Again, now, ocular myasthenia and trauma, we can very well rule out pertaining to the specific history. How do we differentiate between the first 3? This clinical anatomy helps us to differentiate that. So whenever there is second nerve, the optic nerve, it is getting involved. You see the RPD, you see the vision drop, you see the field defect. If the second nerve is involved, it is most likely orbital apex syndrome. How to differentiate between superior orbital fissure and cavernous sinus? the V2 nerves, the second division of fifth nerve, it comes to our rescue. So if V2 nerve is involved, it is likely supraorbital fissure syndrome, and in cavernous sinus syndrome, V2 is not involved. Now, CCF it is an abnormal vascular connection between internal or external carotid artery and that of cavernous sinus, and it is divided anatomically, hemodynamically, and etologically. There are different types, which we'll leave it to the discussion part of it. And the classification, it depends on which arterial section is getting for fissure formation with the cavernous sinus, either ICA, ECA, or the meningeal branches of both. The clinical features are very specific due to involvement of all these specific structures. So pain in the eye due to involvement of ophthalmic nerve, papillae edema due to engorgement of central vein of retina, exophthalmos due to engorgement of ophthalmic veins, dilated and fixed pupils, ptosis, ophthalmoplegia due to involvement of all these craniomotor nerves, and pulsating exophthalmos due to this abnormal communication between the low pressure and high pressure arterial and venous compartments. This is the last 1 minute case, which again is a very young boy, a young man, 34 years old, who had binocular horizontal diplopia for last 10 days, systemically all well, 6/6 and 6. On extraocular motility, he had -2 abduction limitation. So he presented as an isolated left-sided sixth cranial nerve palsy. Again, being very young, without any known comorbidities, we had to image, and surprisingly, again, his anterior segment exam was not very significant, not that much of dilated tortuous vessels, which we could very well evidently see in last 2 cases. So it was relatively quieter eye compared to last 2. And fundus was also normal. And on neuroimaging, we were surprised to see that he did have a left-sided type A baro-CCF, and he underwent coiling and squid embolization of it. And you can see in the last image how beautifully the vascular network has ballooned up post the successful surgery. Again, these are very demanding neurosurgical procedures which need long, very good expertise and long experience with the surgeons. And we thank our, neurosurgical team for, delivering this excellent outcome. So on follow-up, his squint had improved, motility had improved, and he was doing good. So few take-home messages from my presentation. That first, not all red eyes are infections or allergies. Please look for this dilated episcleral vessel tortuosity. Always make sure that you check for the involvement of craniomotor nerves. Localized lesion, why it is necessary? Because as a neuro-ophthalmologist or as an ophthalmologist, we need to tell the radiologist what to look for. So to advise that focused neuroimaging, first you should have the clinical localization and then promptly refer these patients to the neurosurgical team. Thank you.
Thank you, Dr. Ajinkya. That was a very interesting cases, some very interesting cases indeed. And now I invite Dr. Mohan Kanam, who's a consultant pediatric ophthalmology, strabismus, and neuro-ophthalmology at the Center for Sight Hospitals at Hyderabad. So Dr. Mohan is an expert in these kind of presentations. And over to you, Dr. Mohan, for your comments.
Thank you, Dr. Tinku. Thank you, AIOS and IRC for the opportunity. And it's a wonderful presentation, Dr. Ajinkya. If you look at the first case, it was misdiagnosed as an infection. Second, it was evaluated for diplopia, but we overlooked the presentation of the redness in the second case. The third case, it's a completely quiet eye. If you look at the clinical presentation of CCF, it can actually present as a red eye, just like in the first 2 cases, or it can present as a white eye based upon the amount of backflow. So that actually determines if it is a red eye, then it's obvious that most of the time we tend to keep CCF in the diagnosis, but when it's a white eye, that's where our suspicion has to be increased, especially when the patient present with the palsy. That's why we always tell to all our colleagues that image all palsy cases, irrespective of the whether people are involved or not. So that's a dictum as a neuro-ophthalmologist we do follow. 3rd, 4th, 6th. We tend to get at least some amount of clues like enlargement of SOV or loss of concavity of the lateral wall of the cavernous sinus in these cases, where we can pick up subtle findings and we can help in the diagnosis. Not always we need to treat the condition. Sometimes as an ophthalmologist, we also find out that presentations in the early stages so that we can save the life, especially as a neuro-ophthalmologist. And the two things what we usually look or have to look in these patients is like IOP, difference in the IOP, approximately 5 to 6 between two eyes, one. Second, when we are doing applanation tonometer, the amount of movement of Myers, that helps us in identifying that something is wrong with eye. This eye, there is not the regular allergic conjunctivitis or infection. This is a second one. And again, imaging is must in these cases, and they can present as right eye or a nerve pulses. Always we have to localize clinically before we diagnose, we advise the imaging. uh, and these patients also need a regular follow because they tend to recanalize or reanastomose uh, whatever the treated CCF opening with the coil, which is the most commonly used techniques at present days compared to balloon techniques. So not only the diagnosis, even after that, a regular follow-up also helps us in finding the early recanalization of the shunt.
Thank you. Thank you,
Yeah.
Dr. Mohan. You highlighted some very, very important points. And Dr. Grover, sir, anything that you'd like to add?
I think the availability of an interventional neuroradiologist in your hospital is a big boon because these are common cases. I mean, they're not all that rare as we often think. And having a high index of suspicion and getting the right imaging done, eventually getting the DSA done to identify the type of anastomosis that is taking place is important to be able to manage them well. So good to have a high index of suspicion, as has been pointed out, because otherwise misdiagnoses are common. And of course, the type 1 or the direct type is much easier to diagnose, but the most subtle ones may present with more subtle clinical features. And it is there that it is important to diagnose them.
Thank you, sir. Dr. Mohan, sir?
Yeah, lovely presentation. I think it's as Grover sir rightly said, we should have a high index of suspicion, especially when the patient has got a dilated episcleral vessels. Yeah, and I have a patient, sir. I just wanted to ask Grover sir also, and also the panel. I have a patient recently I saw just a few days back, and dilated episcleral vessels, 50-year-old person, and we did the MRI, DSA, everything. And the MRI, DSA, everything showing that dilated superior ophthalmic vein and the cavernous sinus also a little dilated. So, but the neurosurgeon who is an interventional neurologist said it's a congenital variant of that. So we've been following up this patient for quite some time now. I just saw him last week again for after a year or so. But is there anything like that, sir?
Yes, there are congenital AV communications, and they can present in this manner. Yes, certainly.
I thought it was a low flow CCF or something, which has caused this because dilated episcleral vessel, both eyes, and everything was filling into that this thing, no? But you should have as
Other
a
than the type A,
yeah,
may present very subtly.
yeah. And imaging means Mohan Kannan, you are talk about imaging means MRI, brain and orbit, MR venography, as well as DSA as well. Everything.
Sir, based upon the clinical presentation, usually we keep this as a diagnosis. We also include orbital apexis in our differential diagnosis. Unless and until we are very clear about the CCF clinical diagnosis, we don't advise DSA because it's a costly and not available everywhere.
Yeah, yeah.
MRI brain with contrast is a standard investigation. We advise for all of these patients, and that itself will be enough for a diagnosis of CCF. We look for a enlarged or engorged SOV. Along with that, the bulky or the loss of concavity of the lateral wall of cavernous sinus, that itself will help us. And in the MRI itself, if we can send to the same center where they underwent, we can tell them to take a separate sequence called time of flight. They can it can help in identifying the wherever the connections are there, whether it's a direct or an indirect one. Once this is confirmed, then the DSA can be done before the intervention so that they can look at the exact places so that they can
Because
close it.
most here in Chennai where we are practicing, where whenever we send it for MRI, the scan center, of course, the top one of the top scan centers, because she's also a consultant for Netralaya or Shankar Netralaya also, they say that MRI is not good enough. You need to send the patient for DSA. So that's the reason why I'm asking. Yeah.
Sir, if CCF is the clinical diagnosis for sure, DSA is the investigation.
Yeah.
But if it is one of the differential diagnosis, then MRI with contrast is the investigation of choice for me, for my patients.
Okay.
Thank you. Thank you,
Thank
Dr.
you.
Ajinkya and Dr. Mohan.
Thank you. Thank you so much.
Thank
Yeah.
you.
So that brings us to our last case. Dr. Natarajan, you've seen a variety of cases today in this webinar. What do you feel about the young presenters? I think they've
I
done
think
an
it's
excellent job.
wonderful. It was like going through a textbook with
Yeah.
our senior giving the discussion with really revision. And I think the standard is quite high because we just finished conducting the first exam. Dr. Grover will accept. I think the standard here is, anyway, they aim at regular ophthalmology, but here it's really great. I think it was an insight into all subspecialties, and that also the most uncommon presentation in a common way. I
Thank
think
you,
very
sir.
wonderful.
Dr. Mohan Rajan, sir, any parting
No, I'm
comments
very
before-
proud of the Indian ophthalmologists, I would say, today.
Exactly.
Today, after seeing all the presentations from every nook and corner of India,
Yes.
it is not normal presentations. It's all really fantastic presentations.
Yes.
Each and every case was so rare and and very well presented and very well documented, and the way and you see because I'm traveling all over India now, I know exactly even the free paper standard by the postgraduates and the residents have become very, very high now. I think the standard is very good. I think the Indian ophthalmology, I think it's one of the it's the highest moment for the entire thing. I'm very proud of all of you.
Yes.
And yeah,
Agree
very,
with Mohan. I think
Grover.
depth and width of knowledge that the presenters demonstrated and
I
the
was
skill in making the right kind of presentations in a short time where everything was highlighted was very beautifully done. And the discussants were excellent too.
and hats off to Tinku for
Arranging.
conceiving this program, formulating the
Absolutely.
entire. Really great, Tinku, you are.
Yeah.
And
No, it was my pleasure, and I got
we
to
learnt
learn
a
so
lot.
much
We learnt
myself.
a lot. Each of us,
Yes, sir. It
we
was
learnt
quite
a
a
lot.
learning experience. I
Quite
know.
a learning experience.
We did, it was a lot of knowledge was shared. The presentations were just superlative. The discussions were extremely insightful, and all in all, it was a wonderful webinar. Thanks to all our presenters, our discussants, and most of all, the chairpersons who've been with us throughout this long webinar. Thank you so much, sirs, for your presence, Dr. Mohan Rajan, Dr. Natarajan, Dr. Grover. It was so encouraging to have you all here, throughout the duration of the webinar. Thank you so much. And thanks to all the presenters once again. Just wanted to tell you that these webinars are a very regular feature of the ARC AIOS program. So every Thursday we have a PG teaching program where we have a webinar on different topics. And this is a monthly webinar on Friday where we again cover different interesting topics.
Very nice, Tinku.
So thank you so much.
Congratulations, Prashant, for doing a wonderful ARC work.
No, Prashant.
Thanks to Dr. Prashant and also Dr. Deepak Mishra, who was
The entire team of ARC.
Yes, yeah.
Entire team, all the zones.
Great work.
Dr. Prashant is here. Dr. Prashant, any parting comments?
No. Thank you, Tinku, for wonderfully collating such a beautiful presentations, seeking out most of the peripheral ophthalmologists from across the countries, young turks, and also we know well the expertise of all the mentors. And seriously, Tinku, you did a wonderful job along with Deepak Mishra and Dr. Mohan Rajan sir, Ashok sir, and Nati sir. We have taken the ARC to a newer heights, and these are my five fingers: Tinku, Deepak, Srinivas Joshi, Anaga, and Kasturi, who really do wonderful jobs. I just have to delegate and sit upon the laurels which they earn for our
No.
ARC.
You are.
Thank you.
Prashant, I would tell you openly. I can tell in any platform, this is probably the best ARC ever we can have. It's a golden era for ARC, and Prashant, hats off to you.
So Ashok and
Prashant,
we were looking primitive, and you've done a wonderful job.
Yeah, we can tell Prashant, as past chairman of ARC, that you've taken it to much greater heights and you've really built on what we did in the earlier years.
Thank you, sir. Thank you.
All the best.
So
Prashanta.
with that, good night, good night. With that, we bid you a very...
We'll take a group photo.
Yeah, please, let's take a group photo.
Okay.
I'll take. Right.
Sir, एक second, sir, एक second बस हाँ.
Done.
Share it on the group, Nupur.
Yes, ma'am, I'll do that.
Thanks a lot, Tinku. Bye. Good
Thank
night.
you. Good night. Good night,
Good night.
everyone.
Once
Thank you
more.
so much.
Thank
Bye-bye.
you.